Okay, good morning. Can everyone hear my voice? Can everyone hear my voice? Okay, good morning. Welcome everyone to the 26th lecture of Dr. Hyderi Step 1. Thank you for waiting for so long for everyone else to join because it's Monday and everyone needed a little bit of time to join the lectures. And how was everyone's weekend? Hope everyone had a good time. Did you guys have a good time on your weekend? How was your weekend, guys? Did you guys have a good time? Okay, good. Okay, great. That's great. Okay, so thank you everyone for clearing your transactions before our lectures. And to be honest, we would have sent you the lecture links regardless of your completion of transactions. Okay, but because at the end of the day, our lecture links are our lectures are very important for you guys. We understand that, and at the same time, it's important for us to see if the transactions are complete, so that it helps us maintain a proper format. So thank you so much. And if anyone else has left to complete their transactions, please try to complete it at least by today or by tomorrow, so that we can keep on providing you with the lecture links. And with that being said, I know you guys had a good time on your weekend. Did anyone of you guys get some time to do some questions? That's very good. Okay. Okay, that's great. Okay, anyone else? So Dr. Wasam over here, he's the one who did, he did 60 questions. Anyone else who did questions during the weekends? Okay, good. Okay. Oh, happy Diwali. Okay. Uh, hope you had a good time in your holiday. Okay, that's good. Okay, good. Okay, that's great. So it looks like everyone even it looks like you guys got some time during your weekends to do some questions, and that's great. That's amazing. Okay. So with that being said, to be honest, during our lectures for last week, we wanted to finish neurology. Okay, but looking at how vast the subject is and how everyone needed to master every concept of neurology, um, we took our time and we wanted to make sure that every one of you guys understood everything, because that was the only way we can move forward, because we do not expect you guys to spend the rest of your days doing first aid. We expect the rest of you guys, I mean, the rest of the time of your day should be devoted to doing questions. So in order for us to do that, we wanted to take some time in finishing neurology, and that's why we took the whole week. Okay, but hopefully things will speed up by this week, because we have understood the physiology, we have mastered it, hopefully, and that's exactly what I will test in a couple of minutes. Okay, to see if everyone remembers all the concepts. And once that is done, pathology is just a walk in the park. Okay, because neurophysiology, neuroanatomy, and neuroembryology are the hardest ones to master. And if you guys have done that, then pathology should not be hard for you. And for the pharmacology section of neurology, we have our mnemonics and stories and a lot of other things that goes through our lectures. I'm pretty sure you guys know that will help you guys remember all the high yield concepts. Okay, so it's 9:22 as of right now. Instead of wasting any more time, okay, should we start with our recapitulation and revision section of the lecture? Is everyone ready? Okay, great. At the same time, with that being said, okay, at the same time, with that being said, once again, to all the students who have joined the lecture, thank you so much for completing your transactions. And if anyone is left in completing their transactions, please try to make sure you can complete it by tomorrow. Okay, because that will really help us to gather our formats together, the formats of students, so that we can properly plan the schedule and everything. Okay, so please try to do that. Okay, so with that being said, let's start with our first topic for neurology, the one which we will recapitulate with. Okay, so these are the common brain lesions. Do you guys remember the common brain lesions? Do you guys remember the common brain lesions? Can you guys hear my voice? Okay, great. Okay. Okay, perfect. Okay, so what we will do is after every lecture on Monday, okay, after every lecture on Monday, we will be discussing the USMLE Step 1 pattern. We will be discussing the USMLE Step 1 preparations. And if you guys have any questions regarding USMLE, how your prep should go, how day in your life should look like while you are preparing for USMLE Step 1, any questions regarding the actual exam, we would be discussing everything so that you have a complete knowledge of what you're going in for. So that's what we will be doing for our lectures at the end of this lecture. So please try to stick around for the end. Okay, so that's what we will do. And if you guys have any questions regarding your um, lesson schedule or regarding your study preparation, we will be discussing that too. And once again, if you guys have any obstacles which you guys are facing and you need to modify your lecture schedules accordingly, we will help you do that too. Okay, so without further ado, let's start. Okay, so our first question is, so you have a patient who has come to you with a history of trauma. Now the patient has personality changes, the patient has inhibitions, deficits in concentrations, the patient has re-emergence of primitive reflexes. Which lobe of the brain is the patient traumatized in? Very good, and the answer is frontal lobe. Okay. If you have a patient who has come to you with the trauma to the brain, now the patient keeps on looking towards the side of paralysis, towards the side of paralysis. Which part of the brain is the patient traumatized in? PPRF. And what was the mnemonic that we used for remembering paramedian pontine reticular formation damage? Double paralysis, and you would like to look towards the side of 2Ps. That's great. And if the patient is looking away from the side of the lesion, well, which part of the brain is damaged? If the patient, okay, good. It's frontal, I feel. Very good. Okay. So you have a patient who has been diagnosed with a degenerating demyelinating disorder. And now the patient has problems with movements of their eyes to side to side. What is the name of this condition? The patient has been diagnosed with a degenerating demyelinating disorder, and the patient cannot move their eyes from side to side. Okay, the name of the condition is multiple sclerosis, and it's internuclear ophthalmoplegia. Okay, which white matter is damaged over here? And the white matter that's damaged is medial longitudinal fasciculus, and that is good. Okay, next one. If you have a patient who has come to you with problems with reading, writing, calculating, cannot recognize their fingers, cannot differentiate left to right, left from right, dominant parietal cortex damage. Okay, good. Dominant parietal cortex damage. Okay, that's very good. Okay, next one is, if you have a patient who has come to you who has difficulty in forming new memories, what is the name of this condition and which part of the brain is damaged? Okay, good. Okay. If you have a patient who has come to you with a history of alcoholism, now the patient has confusion. The patient cannot walk in a straight line. The patient has involuntary movement of the eyes. What is the name of this condition? Okay, next one. Next one is if you have a patient who has come to you with disinhibition of behavior. Along with that, the patient has hyperorality, hypersexuality, and hyperphagia. What is the name of this condition? Kluver-Bucy syndrome. That is very okay. If you have a patient who has damage to one part of the brain, after which the patient has difficulty in consciousness, difficulty in arisement of consciousness, the patient is comatose. Which part of the brain is damaged? Reticular activating system. Okay, good. Okay. So if you have a patient who has passed away, the patient has unfortunately passed away, and you are helping on the coroner in postmortem, okay, and you see a lesion in the brain, and under microscopic lesion, you see that there is presence of reactive gliosis in the brain, along with vascular proliferation. How long has it been since the patient has suffered from an ischemic stroke? Good. Okay. If I told you that you have the same scenario with the patient who has the presence of eosinophilic cytoplasm and pycnotic nucleus or pycnotic nuclei, how long has it been since the patient has, okay, good, 24 hours. Okay. That's great, guys. You guys could remember everything. Okay, good. Are you guys, okay? Do you guys promise you guys are not looking at the looking at the book while you guys are answering the question? Okay, okay, I believe you. Okay, good. Okay, very good. Okay, next one. Next one is if you have a patient who has come to you with signs symptoms of stroke or cerebral ischemia, how long do you think you have in your hand in order for you to prescribe heparin to prevent cerebral damage or thrombolytics to, to prevent cerebral damage? How long do you have in your hand in order to provide? Okay, good. Okay, now you have another child who has come to your clinic. You are a pediatrician. The child has come to your clinic, and this child, okay, this child has cigarette marks. Okay, this child has burned cigarette marks in her hand. The mother is very aggressive. Okay, and the child has a bulging fontanelle. What is the name of the syndrome? The child has cigarette marks on her hand. The mother is aggressive, and the child has a bulging fontanelle. What is the name of the syndrome? Okay, okay. But what is the name of the syndrome? You are suspecting neonatal interventricular hemorrhage. What is the name of the syndrome? And the name of the syndrome is shaking baby syndrome. Okay, very good. The name of the syndrome is shaking baby syndrome. Okay. And which blood vessel do you think had undergone damage in order for this bulging to occur? Okay, which blood vessel has undergone tearing in order for this bleeding to occur? Germinal matrix. That's good. It's not the bridging veins. Okay. So once again, okay, once again, okay, once again, we are going to talk about the three blood vessels and three types of hemorrhage. Okay. Once again, we're going to talk about the blood vessels and three types of hemorrhage. First of all, if you have a patient who has come to you with a lesion with damaged with a damaged middle meningeal artery, what type of hemorrhage are you expecting in the patient? Epidural. Okay. If you have a patient who has come to you with hemorrhage of the bridging veins, what type of hemorrhage are you expecting in the patient? Subdural. Okay. If you have a young patient who has come to you with lesions of the germinal matrix, what type of hemorrhage are you expecting in the patient? Germinal matrix. Okay, good. If you have a patient who has come to you with ruptures of aneurysm, what type of bleeding are you expecting in the patient? Subarachnoid. Good, very good. Okay, if you have a patient who has come to you with long-standing hypertension, now the patient complains of stroke-like episodes. Okay, what type of bleeding are you expecting in the patient? Intraparenchymal. That is very good. Okay. Okay, that is very good. So we will storm through the sign symptoms of stroke very quick. Okay, I will describe the sign symptoms, and I will expect you guys to mention the arteries in which you suspect the patient might have ischemia in. Okay, the first one is your patient who has come to you with paralysis of the right side of the face, okay, and right side of the upper limb. Along with that, the patient has difficulty in talking or aphasia. Which blood vessel do you think has undergone ischemia? Okay, so Dr. Hassam is specific. It's LMCA, meaning even Dr. knows. Okay, so MCA is the right answer, and the left middle cerebral artery is the right answer because contralateral paralysis. Okay, that's very good. If you have a patient who has come to you with paralysis of the left lower limb, along with that, the patient has urinary incontinence. Which one of the arteries have undergone ischemia? And your answer is right, anterior cerebral artery. And what was the mnemonic that we used for urinary incontinence and anterior cerebral artery ischemia or infarction? Okay, good. Okay. If you have a patient who has come to you with paralysis of all four limbs with absence of cortical signs. Uh, Okay, very good. Lenticular is right. Okay, great. Okay, so do we have any student over here who is absolutely new to our lectures? Do we have any student over here who is absolutely new to our lectures? Anyone who is absolutely new to our lectures? Do we have any students? Okay, so we would expect every one of you guys have done our lectures in the past. Okay, good. So no new students then. Okay, good. So if we had new students, then we would be describing how our lectures usually run. Okay. Okay, good. So the first half an hour to 45 minutes are usually completed in doing the revision and recapitulation. So that's that. Okay. After that, we will start our regular first aid readings. Okay. Next one. Next one is if you have a patient who has come to you um, with paralysis of the right upper and the right lower limb. Along with that, the patient has decreased vibration and position senses. Along with that, the tongue has deviated to the right side. The tongue has deviated to the right side. Which one of the following arteries do you think has undergone ischemia? Okay, very good. The artery is anterior spinal artery and specifically the right-sided anterior spinal artery. Okay, good. Okay, next. If you have a patient who has come to you with difficulty in deglutition, difficulty in talking because the patient has hoarseness, along with that, the patient has the patient has vertigo. The patient has the patient also has decreased pain temperature sensations, and okay, good. It's pica, posterior inferior. And what if I told you you have the same patient who has facial drooping instead of dysphagia and hoarseness? Facial drooping instead of okay, good. So it's good. So it's anterior inferior cerebellar artery. Okay, good. Now you have another patient who has come to you with a condition in which the patient cannot move any limb of the body, only the eyes. Okay. And the patient's consciousness is impaired and the eyes can move from side to side, but the eyes cannot move from vertically. Okay. What is the name of the syndrome? The name of the syndrome is locked in syndrome. Okay, good. Next one is if you have a patient who has come to you with contralateral hemianopia with macular sparing. The macula is spared because it's supplied by MCA. Which one of the following arteries have undergone ischemia? The answer is posterior cerebral artery. Very good. Okay. Okay. Next one. Next one is if you have a patient who has been involved in a traumatic accident, which involved rapid acceleration and deceleration. Okay, rapid acceleration and deceleration, and now the patient presents with multiple bubble-like appearance in the CT scan. Okay, and the patient is in a comatose or in a vegetative state. What is the name of this condition? Diffuse axonal injury. Okay, good, very good. Okay, okay. So the next thing which you guys would do is is do you guys remember? Do you guys remember the table for aphasia, which we drew in our last lecture? Okay, in our table for aphasia, which we drew in our last lecture, okay, what we used was FS NFS, GCPC, PRGR, and then BCW and MMS. Okay, so I will give you guys exactly 5 seconds to draw that table out. Okay, I will give you guys exactly 5 seconds to draw that table out and answer the questions which are regarding aphasia. Okay, so exactly 10 seconds. Please draw the table out. Okay, did you guys draw the table out? Are you guys done drawing the table? Okay, good. So the first question is if you have a patient who has come to you with poor comprehension, fluent speech, and poor repetition, what is the diagnosis? Everyone? Okay, the diagnosis is Wernicke's aphasia. Next one, if you have a patient who has come to you with poor comprehension, non-fluent speech, and good repetition. Poor comprehension, non-fluent speech, good repetition. Okay, good. The answer is transcortical mixed aphasia. Okay, next one. If you have a patient who has come to you with good comprehension, non-fluent speech, and poor repetition, Broca's. Next one. If you have a patient who has come to you with poor comprehension, fluent speech, and good repetition. Okay, good. If you have a patient who has come to you with good comprehension, fluent speech, and poor repetition. Good comprehension, fluent speech, and poor repetition. Okay, good. The condition is conductive aphasia. Okay. So once again, the table is important. So do you guys realize how easy it is to answer all the questions when you have when you have the table drawn? Okay. Did every one of you draw the table out confidently? Did you guys face any difficulties or have any difficulties going back and looking at the table? If you did, then we would make you understand the table again. Okay, good. So if the answer is no, then we can move on. Okay, very good. Okay. Okay. Okay, you are new. Okay, so welcome to our lectures. What we are studying for this group of sessions is we started from cardiovascular system a while back, a month back. Okay, and now we are targeting on finishing neurology. Okay, and since you are new, okay, that's what I was asking because I was looking for our new students because I wanted to let you guys know that the first half an hour to 45 minutes of our lectures are focused on completing our revision and recapitulation for the previous lectures. Okay, and for this group of lectures, what we are doing is we are trying to finish neurology. Okay, we have finished quite a bit of pages, and after we are done finishing neurology, we will keep on moving on. And what we will be doing is we would be taking the lectures once again for all the topics which you have missed. Okay. By now, you have missed cardiovascular system, endocrinology, gastroenterology, musculoskeletal, connective tissue, skin, neurophysiology, neuroanatomy, neuroembryology. Okay, so what we will be doing is we would be taking those lectures again for you. So you do not have to worry about the lectures which you have missed. Okay, we will be taking those lectures again for you and for all the others who have joined our lectures. And so this is a 3 to 4 hour lecture. And what we would be doing is after our revision and recapitulation, we would be focusing on finishing our regular first 8 pages. We try to focus on finishing a minimum of 8 to 10 pages per day, but we have not been succeeding in doing so for the last 1 week because of how tough neurology is. Okay, but hopefully we would be back in our track by this week. And the page number which you have been asking for is page number 517, from where we will be starting our 517, from where we would be starting our today's lecture. We would be starting from seizures. Okay, so let's go to page number 517, everyone. And let's begin with our today's lectures. It's 9:44 as of right now. Okay, and let's begin. Is everyone ready to start the lecture for today? Okay, okay, perfect. Okay, let's start then. Okay, so for this topic over here, what we will be doing is we will be starting with seizures. Okay, I'm pretty sure you guys know what seizures are. What are seizures? Seizures are basically, okay, let me paint you guys a normal picture of what a seizure is, and then you guys would understand very well. So seizure is basically an asynchronized, okay, seizure is basically characterized by synchronized or asynchronized neuronal firing, which helps you, which I mean, which results in the transmission of excessive impulses and resulting in excessive bodily movements. Okay, that's what seizure is. That's what seizures are. And the thing is, the seizures are generally divided into two big categories. We have your focal seizures, and then we have your generalized seizures. Okay, so for the focal seizures, what we have is let's discuss the differentiation first. So in your seizures, first of all, seizure is an asynchronized or synchronized high neuronal firing, which results in asymmetric or symmetrical movements of the body, which due to the excessive transmission of bodily impulses. Okay, so what's happening is, let's say that you have a patient who is undergoing seizure. Okay, so let's say this is the part of the brain. Okay, this is the another part of the brain, and this part of the brain will send impulses all the way to this part of the body. Okay, and what would happen is these impulses are normal, steady, readily impulses. Okay, and these are controlled by sending the impulses to cerebellum, basal ganglia. Okay, and then what happens is if you have a patient who has asynchronous discharge of impulses, what would happen is, let's say that this is the impulse that is being sent from the brain to the hand. Okay, to the hand. And what would happen is, instead of sending readily impulses, this brain right now would send a lot of impulses which are asynchronized. Okay, so this will result in in excessive movement and shaking of the hand, and this is known as your seizure, the patient who is undergoing seizure. Okay, and the thing with seizures are the seizures could be classified into two. That is your partial seizure or your generalized seizure. Partial is basically a part of the brain which is involved in transmitting the impulses, and generalized seizure is most of the whole part of the brain. Okay, the whole part of the brain which is responsible in sending the impulses. Right now, if the patient has partial seizure, what we try to see if what we try to see is if the patient has their consciousness intact or not intact. Okay, if the patient has impaired consciousness, meaning that the consciousness is not intact, that let's say the patient has passed out, okay, or the patient has been unconscious after the seizure, then this type of seizure is known as complex partial. And if the patient has a seizure, and let's say the patient has a seizure in which the patient has a seizure followed by no impairment of consciousness. Okay, let's say his consciousness is intact and he remembers exactly what happened. This type of seizures are known as simple partial seizures. Simple partial seizures. Okay, and once again, if we go back to the generalized seizure, meaning where all the layers of the brain, I mean, all parts of the brains are involved, it could be widely divided into five categories. Okay. And for these five categories may look a bit overwhelming right now, but we would break it down for you so you have nothing to worry about. Okay. So out of these five categories, the first important one that I want to talk about, okay, the first important one that I want to talk about is absent seizure. Okay, absent seizure. Okay, absent seizure. And this is very important because absent seizures are a bit different from all the other type of generalized seizures. What happens with absent seizures are, in absent seizures, you have patients who have this tendency of looking blank. Okay, like this boy over here. Okay, like this boy. What happens is the boy is looking blank, staring into the staring somewhere. Okay, and what happens is if the boy keeps on looking blank like this is the part where the boy is undergoing an absent seizure, meaning, to be honest, the boy is absent in his own presence. Okay, the boy has no idea what's going on and the boy does not remember. So as you can see, this picture of this young little boy who is doing completely fine and he's smiling, and out of nowhere the boy just starts looking blankly at the wall or starts looking blankly at somewhere, and it's usually noticed by a guardian, a teacher, or their parents. Okay, so the way you will get the questions about absent seizures is basically a young boy or a young girl will be presented to you by their teacher or by their mother, and the mother will tell you that during classes there are complaints by the teacher that the boy stares off or dozes off and stares at the wall for a long period of time, and after when he's asked what's going on, he does not remember. And if you hear these type of complaints, please try to consider that you have a patient who has been undergoing absent seizures. Okay, absent seizures. And let's see if you guys have been doing questions. If you have a patient who is undergoing absent seizures, okay, if you have a patient who is undergoing absent seizures, what type of drug will you prescribe to your patient who is undergoing absent seizures? What type of drug will you? Okay, ethosuximide. Another drug, please. Ethosuximide or valproic acid. Very good. Okay. You can either prescribe ethosuximide or you can either prescribe valproic acid or sodium valproate. Okay. So basically that's it. Okay. Okay. So to the students who has just joined the lectures, all we did was we discussed absent seizures. Okay. We discussed seizures, focal seizures, and generalized seizures. And in generalized seizures, we described absent seizures. Next one. Next one, which we want to discuss is atonic seizures. Atonic seizures are basically loss or this type of seizure where the patient loses the tone of the body. So the whole tone is atonic, meaning that in these type of patients there will be paralysis or flaccidity, if you could think about it. And after the seizure, the patient would drop to the floor. The patient would just drop to the floor, and this is known as atonic seizure or atonic seizures. Okay, next one is myoclonic. Myoclonic is basically you can say a lot by the name, that is myoclonic, meaning that there is contractions of the muscles. Okay, so myoclonic, that's what it is. And what's happening over here is that the patient is undergoing quick and repetitive jerks. Okay, so there's repetitive and quick movements of the body, and that's a myoclonic seizure. Next one is a tonic seizure. Tonic is basically meaning that there is an increased tone or hypertonia. There's an increased tone or hypertonia of the body, and the patient has increased stiffening. Okay, so and the patient has increased stiffening of the body, and that's what it is. Okay. Another one is tonic clonic or grand mal seizures. Tonic clonic are basically alternative of your stiffening and alternating of your alternating of stiffening and alternating of the bodily movement. So either the patient could be in a tonic phase in which the whole body is contracted, or the patient could be in a clonic phase in which there could be movements of the body. That's what it is. Okay. So once again, how many types of seizures do we have? We have two types basically, partial and generalized. In partial, we would like to see if the patient has impaired consciousness or not. If the patient has impaired consciousness, it's complex. If it's not impaired, it's simple. In generalized seizures, we have absence, which is the most important. Okay, you will get a lot of questions from here. We treat absent seizures with valproic acid and ethosuximide. Then the next one is atonic. The patient will drop to the floor. Then the next one is myoclonic, in which there is quick repetitive movements. The next one is a stiffening type of seizures in which in the patient's whole body gets stiff. Okay, and the whole body gets stiff. And the next one is tonic clonic or grand mal seizures in which there's alternating stiffening and movements of the body. Okay, so with that being said, did you guys understand all the different types of the seizure presentations? Yes, no? Could I get some answers, please? Okay, good. Okay, so the only way I can move forward is as if I have confirmed you guys have understood what we have just talked about. Okay, so we will just go through a very fast recapitulation to see if everyone has understood. Okay, so first of all, you have a patient who has come to you. All of a sudden, the patient has undergone excessive stiffening of the body. What is the type of seizure you're dealing with as a physician? Excessive stiffening of the body. Very good. Now you have a patient who has come to you who has who has a complaint that the patient was doing fine while in the bathroom. The patient suddenly dropped to the floor. The patient suddenly dropped to the floor and the patient felt flaccidity. Okay, good. The condition is atonic seizure. The next one is if you have a patient who has come to you along with a guardian, and the patient's guardian complained that the patient went through an episode of quick repetitive jerks. What is the type of seizure that the patient undergone? Myoclonic, very good. Now the next one is if you have a patient who has come to you that the patient remembers the patient having a seizure, but the patient did not um, lose their consciousness. Okay, what is the name of the seizure, please? Simple partial. Very good. Now the last and the most important one is if you have a patient who has come to you, the patient is a young patient accompanied by their mother. The patient's mother complains that the patient's teacher said that this young patient of yours stares off into the abyss in the class. What is the name of, of this procedure? Absent seizures. And which drugs do we use to treat absent seizures? Ethosuximide, or if the patient is allergic to ethosuximide, what do we use? Sodium valproate acid. Okay, good. Okay. And okay, and let's say if the patient has recurrent seizures, if the patient keeps on having seizures. Okay, so let's say if you have a patient who keeps on having seizures and the seizures are unprovoked. Okay, so basically if a patient has seizures, there are a couple of things which we have to consider. First of all, what we can consider is the most important and the most easy one, that is your metabolic changes in the body, right? If there is hypoglycemia, or if there's hypotension, if there's hyponatremia, hypo or hyperkalemia. Okay, and if those are the metabolic changes, because those are the most common. Along with that, there could be infection, let's say meningitis. There could be trauma or tumors of the brain. There could be ischemia, and these are some of the common causes of seizures. Okay, and these are provoked stimulus. So the stimulus is provoking the brain to undergo seizures. What if you have a patient who has unprovoked seizures? What is the name of this condition? It's not status epilepticus. Okay, the name of this condition is just epilepsy. Epilepsy, good. So what is epilepsy? Epilepsy is basically your disorder of recurrent unprovoked seizures. Okay, so do you guys understand now? Did you guys understand the difference between seizure and epilepsy? Did you guys understand the difference between seizures and epilepsy? Okay, good. Next time, if anyone asks you to differentiate between seizure and epilepsy, what would be your answer, please? Because this is a you world question. Un- what would be your answer? Okay, unprovoked. So very good, Dr. Khatun. Okay, so that's what it is. Unprovoked or presence or absence of a bodily stimulus. Okay. Next one. Next one is if you have a patient who has continuous seizures. Okay. Next one is so usually the seizure episodes they usually do not last for more than 5 minutes. So usually the seizure episodes they do not last for more than 5 minutes. If it does last for more than 5 minutes, we have a condition which is known as status epilepticus. We have a condition known as status epilepticus, in which the patient is having recurrent seizures, and it's a very, very important medical emergency because the patient has to be attended right away. Because if the brain keeps on undergoing seizures for more than 5 minutes, what you have to understand is by seizure, the brain is involved in transmitting impulses. And the brain can only transmit this wide variety of impulses for a long period of time, after which the brain will shut down and the patient will die. The patient will experience brain death. So this has to be controlled right away. So continuous, more than 5 minutes of recurrent seizures are known as status epilepticus, and this has to be controlled. And do you guys have any idea about how we treat a patient with status epilepticus who is undergoing status epilepticus? How do we treat a patient who is undergoing status epilepticus? General anesthesia, okay. So let's say you do not have general anesthesia in the emergency department. What do? Lorazepam, do you give it IV, IM? No. Okay. So that's the thing. So let's say you have a patient who is undergoing status epilepticus, meaning excessive movement of the body. How can you prescribe IM or IV to a patient who is moving continuously? Okay. So it's absolutely impossible for you to prescribe IV or IM to a patient who is undergoing status epilepticus. Maybe IM is possible, but have you guys heard about per rectal administrations of diazepam? Per rectal? Yes, but okay. Okay, good. So what we do is in a patient who is undergoing status epilepticus, we do not prescribe IV or IM route for administrations of any type of sedative or any type of benzodiazepine. So what we basically use is we use a benzodiazepine, and the benzodiazepine is administered per rectal. Per rectal, through the absorption of the rectal veins, the blood reaches the circulatory system and the blood, and the drug helps in stopping the seizures. Okay, so that's what we use, and this is a high yield UL question, so please write it down. We talked about two treatments, one for absent seizures and one for status epilepticus. Okay, that's what we talked about. Okay, next one. Next ones are basically the types of seizures that we have just discussed. We discussed all of these. Okay, so I'm not going to go into any more details of the seizures over here. Okay, and another thing that we have to talk about are the causes, and we also talked about them. As basically the causes are your metabolic dysfunctions, then you have infections, then you have trauma, tumor, stroke. And the thing is, the questions in UWorld, okay, the questions in UWorld are basically from this table over here. If you can identify what type of seizure this is, okay. So the identifications of the seizures are important. So next time, what you have to do is if you can when you are doing a revision or recapitulation, all you have to do is focus on reading the table over here. Okay, for all the students who finds difficulty in remembering what these seizures are, only then they can go and look at this text over here. Okay, that the fact that myoclonic, tonic, and these are that's what it is. Another thing that you can realize is in tonic clonic, there are one or two other things which are happening. It's basically the patient has tongue biting and the patient has urinary incontinence. But this is very what can I say? This is very expectable. Okay, you can expect a patient who is undergoing tonic-clonic seizures that these type of patients will have tongue biting, and these type of patients will have urinary incontinence. So that's what it is. Okay. Next one. Next one. What we will talk about. So are we good in moving forward with seizure? Okay. What are the conditions going from partial seizures to tonic-clonic seizures? Okay, we will discuss about this. Anything else? Does anyone have any more question? Automatism. Okay. Okay. What is automatism? The automatism is basically you perform an action without your conscious intention. Okay. Automatism is basically you perform an action without conscious intention. And are you talking about automatism in terms of seizures, or are you talking about automatism in terms of differential diagnosis? Complex partial. Okay. So what happens in complex partial? Once again, what happens in complex partial is in complex partial seizure. These are basically foci or a partial seizure in which the patient has impaired consciousness. Along with that, the patient also has your along with that, the along with that, the patient also has a condition in which the patient has and along with that, the patient also has a condition in which the patient has a seizure in which there's involvement of one part of the brain only. Okay, and what's happening with automatism is basically the performance of one's action in which the patient has then in which the patient performs an action without an active consciousness or without even a thought or intention. So are you trying to differentiate, or what is the question that you face so that we can break it down? So these are the two different terms which I just talked about. Now, what is your question, Dr. Adhanom? Epilepsy is just several seizures. Okay, so basically epilepsy is basically seizures which are occurring without a stimulus. Okay, that is epilepsy. Okay, so hope that answers your question, Dr. Hussam. And Dr. Adhanom, what is your question? I have discussed complex partial, I have discussed automatism. Do you want to talk about their association together, or what was the question? I did not understand. If you could just please repeat the question, and either that or we can move on. Complex partial and their association. Okay. So the association of automatism and complex partial is basically, are you asking about how you can differentiate complex partial from automatism, or what is the
Hello, hello.
yes, doctor, what is your question, please?
Yeah, my question is in the complex partial, it is saying patient has impaired consciousness and they also
Mm.
have automatisms. Therefore, my question is, what are the clinical manifestations of automatism to
Okay, that is your
recognize?
question. Thank you. Thank you for asking the question. That makes everything very clear. Thank you. Okay, so what Dr. Adhanom is asking is complex partial over here has impaired consciousness and complex partial has automatisms. And what is the clinical manifestations of automatisms? Okay, so first of all, in complex partial, okay, what's happening is at first of all, since at first the patient has impairment of consciousness, meaning that there is a partial or there's a part of the brain that is only involved, meaning that a focal part of the brain, okay, that is only involved. So the patient has impaired consciousness. Along with the fact that the patient has impaired consciousness, the patient also undergoes type of the patient also undergoes a type of condition in which the patient performs an action without his consciousness without his paired consciousness or without thinking about an action. That's what they meant by automatisms, meaning that the patient is performing actions. Let's say you are moving your hand in a very haphazard manner, but you are not thinking about moving that hand in a haphazard manner. And that thought of not thinking about moving it, but still moving it, this condition is known as automatism. Okay, so the clinical manifestations of automatisms are exactly the same thing which you can expect in a patient who is having a seizure. That's what it is. So if you think about it, most of the seizures are automatism are most of the patients with seizures are undergoing automatisms by themselves. Okay, so first aid has its ways of mentioning certain words which can make things a bit confusing. Okay, but basically what you have to focus on is automatism is basically a term used for movement of the body without a proper thought, action, intention, or consciousness. So that's what it is. Okay, so the clinical manifestations of automatisms are the same as the movement of complex partial seizures. Okay, so are we clear now? The treatment of status epilepticus, please. Okay, the treatment of status epilepticus, it's basically rectal administrations of diazepam. Okay, diazepam, what we do is we administer rectal diazepam. Are we clear? We do not try to use intravenous or intramuscular administrations because you cannot access a muscle or access a vein properly because the patient is moving continuously. So we administer rectal drugs. Are we clear now? Okay, perfect. So let's move on, guys. Okay. Thank you so much for your questions. Makes everything a lot clearer. Does anyone have any more question until we move on? Because neurology is a very hard topic and I want to make sure everyone is clear. If needed, please read through the text and see if anything confuses you. Yes, what is your question? Where is your question? Let's see, Dr. Karbasi, where is your question? What are the conditions going from partial seizure to tonic-clonic seizure? Okay, so basically your question was, what are the conditions or there are, okay, so the thing is partial seizure is one part of the brain that is involved and complex, okay, wait, what was your question again? Partial seizures too? Tonic-clonic, okay, so that is the question. Okay, so basically partial seizure is basically one part of the brain that is involved. In tonic-clonic, this is a generalized type of seizure. So what happens is if the patient keeps on having partial seizure for a long period of time, this foci that is over here, okay, this foci and that is over here can keep on moving on through the whole part of the brain. And then when the whole part of the brain is involved, the patient will undergo generalized seizure. But this is highly unlikely. Why? Because patients with partial seizures who are experiencing these type of seizures, their symptoms are controlled very soon or very easily. Okay, because if the patient has impaired consciousness, then the seizure stops. But for some reason, let's say if the seizure keeps on happening for a long period of time, let's say if the patient undergoes a sort of status epilepticus from a partial seizure, okay, if that's what happens, then you can expect your patient to have a tonic-clonic seizure. But this is highly unlikely that these patients with partial seizures will experience tonic-clonic seizures. Are we clear? Are we clear? Okay, perfect. Okay. So I guess we can move on. Okay. So the next thing that we will talk about is fever versus heat stroke. Okay. So what is fever and what is heat stroke? And to be honest, this looks extremely easy, but please do not take this lightly because you will get multiple questions from over here. Okay. So first of all, let's discuss fever. What is fever? Fever is basically when you have an infection in the body, there's release of cytokines, infection or inflammation, you have release of cytokines. And these cytokines are responsible for causing your fever. Now, I'm sure you guys would be expecting my question about which cytokines are involved for causing fever, because we talked about this in our UWorld notes. And can I get last answers, please? TNFA, IL-1, IL, okay, IL-6 to some extent. Okay, so out of all of this, which cytokine is extremely important for causing seizure, which changes the setting point of temperature of the hypothalamus? Which cytokine is involved? Okay, very good. So IL-1. Okay, and if I have to talk about hypothalamus, can we please talk about which nucleus of the brain does the interleukin-1 go and work in order to increase the body temperature? We talked about the nucleuses of the hypothalamus, which are involved for temperature regulation. Which nucleus do we talk about for increasing body temperature? Increasing body temperature. Why do we only have 2 students who have answered about this? Okay, good. Okay, so now we are getting the answers. Okay, good. Okay, guys, good. Okay. That's what it is. Okay, good. So they will go and work on the nucleus and they will set or increase the body temperature. Let's just do 1 minute of quick revisions of the hypothalamic nucleus, please. Okay, so what are the nucleus of the hypothalamus? First of all, what is what does the lateral nucleus of the hypothalamus, what is the lateral nucleus of the hypothalamus involved in? Fast answers, please. Hunger. How about the ventromedial nucleus? Ventromedial. And your nucleus. And cooling and sympathetic or parasympathetic. Okay. Posterior. Posterior. Eating and sympathetic. Okay. Okay, supraoptic, supraoptic, ADH and oxytocin. Okay, preoptic, okay, good, good. So that's what it is. Okay. Okay, so let's not go away from our discussion in hand. Thank you guys for remembering all the nucleus of the hypothalamus. Okay, so once again, okay, so let's go back to fever. Fever is basically the cytokines that are that are released during infection or inflammation, and these increases the bodily temperature. And heat stroke is the inability of the body to dissipate heat, meaning to inability of the body to disperse or distribute the heat. Okay, this is known as heat stroke. And please write, do a circle around this or do whatever you can. Okay, put stars over here. What is heat stroke? Inability of the body to dissipate heat. Do the stars and do the underlinings that you need to do, okay? Because this is extremely, extremely high yield. And this is the exact same line which will be used in your U world if they want to direct you to heat strokes, okay? So U world has their tendencies of using certain lines that they want to use in order to direct you to certain things, right? And I'm pretty sure you guys have understood or grasped how UWorld works. So UWorld has certain descriptions of certain conditions, okay, certain descriptions of certain conditions in which they will direct you to a certain pathology. For example, if they talk about eosinophilic cytoplasm with pycnotic nuclei of the brain, okay, what is the condition that they are directing you to? What is the condition that they are directing you to? Eosinophilic cytoplasm with pycnotic nuclei. Necrosis, or basically what they are directing you is ischemia or stroke, okay? And this is how they direct you to certain pathologies. And inability of the body to dissipate heat is basically their way of telling you that the patient has heat stroke. So this is an extremely important line. So please put your stars over here. Okay. Next one is the temperature. Temperature in fevers is usually less than 40 degrees Celsius. And in heat stroke, it's above 40 degrees Celsius. Okay. That's what it is. Okay, next one. Next one is okay. So do you guys do we have doctors over here who are who measures temperature in Fahrenheit in your hospitals? Fahrenheit or Celsius? Do we have any Fahrenheit doctors over here? Doctors measuring temperatures in Fahrenheit. Fahrenheit. Okay, good. So Fahrenheit. So basically, what you can expect is heat stroke is above, let's say, 106 to 107 degree Fahrenheit. Okay, so that's what it is. Okay, so 106 to 100, 107. That's what it is. Okay, next one. Next one is the complication. Complications are basically the complication of a fever is febrile seizures. Okay, so what happens is if the patient has a fever, has a long-term fever for a long period of time, it's basically young patients, they undergo seizures, and these are known as febrile seizures, and these seizures are accompanied by a high body temperature. That's what it is, and it's benign, meaning that they will self-resolve by themselves, so there's absolutely nothing to be worried about. But in heat stroke, what you have is the complications are basically CNS dysfunction and organ damage, ARDS, and rhabdomyolysis. And what happens is in, if you have an increased amount of body temperature that is more than 106 to 107 degree Fahrenheit or 100 or more than 40 degrees Celsius, this disrupts the homeostasis of the body. Okay, this disrupts the homeostasis of the body, and every organ of the body undergoes metabolic reactions, right? And we need a certain amount of enzymes that needs to work in a certain temperature. Okay, so if the temperature of the body is increased, there's denaturations of those enzymes, meaning that those enzymes do not work. As a result, those metabolic pathways are not working. And as a result, if those metabolic pathways do not work, we know what happens when a pathway does not work. There's accumulation of substances, and those accumulation of substances due to lack of working of a pathway results in these conditions. First of all, the effect of brain, okay, that is CNS dysfunction. Then they have end organ damage. Then they have respiratory distress syndrome and rhabdomyolysis. Rhabdomyolysis is basically your breakdown of skeletal muscles. Next one is fever management. I'm pretty sure you guys know exactly how you can manage a fever. Every layman knows that administrations of paracetamols or acetaminophenes or ibuprofens are important. Okay, along with that, if the patient has infection, then the underlying infection has to be administered. I mean, the underlying infection has to be addressed. by treating the patients with proper antibiotics. But if the patient has heat stroke, okay, if the patient has heat stroke, what you have to do is you have to use an aggressive method in cooling the patient. So let's say you use an ice bath, okay, you use an ice bath and you use that rapid external cooling to take the temperature of the patient down. Along with that, what you do is you use IV fluid administrations because excessive increase in body temperature can result in dehydration. And when you do an electrolyte count or serum electrolyte, you try to correct the sodium and potassium levels. That's what it is. Okay. Out of all of this, the most important thing that you have to realize is inability of the body to dissipate heat, and this is U world, uh, your U world direction of heat stroke. Okay. Are we clear about fever and heat strokes? Fever and heat strokes. Are we clear? Okay. Okay. Good. Good. Very good. Next one. Next one is headaches. Okay. Headaches. Headaches are extremely important. Okay. So headaches are extremely important, and so basically, headaches are basically what 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 these headaches are that you have to deal with. And for your purpose of USMLE step one, you have to have the proper ability to diagnose cluster migraine and tension headaches. Okay. Along with that, you will also have to diagnose these headaches from headaches of meningitis, headaches of subarachnoid hemorrhage, with headaches of trigeminal neuralgia. And we will be discussing each and everything in detail, so you have nothing to be worried about. Okay. So basically, what happens is first of all, let's talk about the classifications of the headache. The first one is a cluster headache. Okay. And a cluster headache is basically it's a unilateral, meaning that it will happen on either one side. It will stay for around 15 to 3 hours, around 15 minutes to 3 hours. And the pain would be surrounding the eyeballs or the pain is a periorbital pain. Okay. The pain is a periorbital pain. And what's happening over here is in cluster headache, the pain is on a severity. So if you ask the patient how bad is your pain, and you ask the patient from 0 to 10, if you give the patient a 0 to 10 and ask the patient that what is your pain level from 0 to 10, the patient would say that my pain level is 10, because these type of headaches are basically suicidal headaches, meaning that the headaches are so bad that the patient is close or is almost suicidal, and that's how bad it is. Because these headaches, what they are is they're also associated with lacrimations, meaning that there's tearing and rhinorrhea. Okay. And what you have to do is, if you have a patient like this who has cluster headaches, so basically cluster meaning periorbital pain along with lacrimation and rhinorrhea, what you have to do is you have to treat the patient with 100% oxygen. Okay. You have to treat the patient with 100% oxygen, sumatriptans or triptans, and we will talk about how triptans work in a couple of minutes. And and for prophylaxis, what we do is we give calcium channel blockers, which are verapamil. Okay. We give verapamil. And the main reason why these headaches usually occurs are because that there could be irritations of the structures of the dura mater, cranial nerves, or extracranial structures, meaning that let's say for cluster headaches, there could be irritations of the structures around the periorbital area, to the lacrimal glands, okay, to the rhinorrheal glands, and that's how the patient gets cluster headache. So basically, what your questions are, these are the descriptions, and this will be your answers. So the questions will come from here, and your answers are expected from this side over here. Okay. So your diagnosis is is your answer, basically. So that's what it is. Okay. So next time if you hear a question about a patient who has come to you with unilateral periorbital pain with lacrimation and rhinorrhea, immediately you should start thinking about cluster headache. Okay. Immediately you should start thinking about cluster. Next one. Next one is migraine. I'm pretty sure you have all had friends and family who experience from this condition. This condition is known as migraine, in which the patient has a unilateral headache, and the headaches, they will usually last for 4 to 72 hours. Okay, and the most common cause, or the most important cause for migraine, is due to irritations of the trigeminal nerve. So we have the trigeminal nerves, meaning the ophthalmic, maxillary, and mandibular divisions of the trigeminal nerves, and the patients have irritations of the trigeminal nerves, either that or the patients have meninges or blood vessels irritation. Okay, but the problem is for migraines to occur, before the episodes of migraine begin, the patient undergoes a small episode which is known as an aura. Okay, so what is an aura of the migraine? Does anyone have any idea what is an aura of the migraine? What is a migraine's aura? What do you mean by aura? Smell and what else? Signs for the patient. What else? Anyone? Okay, so what the patient that usually experiences are they usually experience okay, so we have Dr. Jordan over here who has mentioned flashing lights and zigzags, and that's exactly what it is. Okay, so what happens is the patient experiences some sort of disturbances, like they experience a change in smell. Okay, so we had one doctor who said a change in smell. There could even be change in hearing. Okay, along with that, what the patient experiences, they experience rapid flashes of light, blind spots, or vision changes, or tingling in the face, or tingling in the hands. Okay, and that is basically a warning that basically the patient will have an onset or an episode of migraine. Okay, so if you have a patient who comes to you with the complaints of headache, and they tell you that okay, so before the onset of my headache, I go through an episode in which I see flashes of light. I see zigzags. Okay, I have a change in my smell and these things, and then my headache starts. And if you hear about these type of patients, immediately you should start thinking about migraines, because what the patient is describing over here is the presence of an aura. Okay, so that's what it is, the aura. Okay, that's that. Okay, and another one is migraines are basically happening because of the release of vasoactive peptides. Okay, and there will be vasoactive release of neuropeptides. So these are some high yield ones, and I'm sure I've talked about this in our URL lectures. Okay, that how you need substance P and calcitonin gene related peptides. So CGRP and substance P. Also, so that's what you need. Okay, so you need substance P and calcitonin gene related peptide for these type of headaches to occur. And that's that. Do you guys remember we discussed about this in the U World notes? Who remembers discussions of these things in the U World notes? Anyone? Okay, good. Okay. So that shows that you guys are reading the U World notes. Okay. Are you guys reading the U World notes? Are you guys reading the U World notes? Okay. Okay, so to all the new students, you have nothing to worry about, because since this is your new class, you have no idea about the UWorld notes which we provide. We provide UWorld notes after the end of our lectures, and I would expect you guys to read the UWorld notes. And the reason for which I'm going to tell you why. It's because if you keep on storing the UWorld notes for a long period of time, at the end of your lecture, these UWorld notes will become a burden for you. Okay, and it will be extremely difficult to read and to read everything. Okay, so please read let's say 1 or 2 pages of the UWorld notes every day, so that it's easy for you to recall and review everything. So we discussed about this in the UWorld note, how the patient has an aura, how the patient has release of vasoactive substances such as substance P and calcitonin gene related peptide. Now, how do you treat a patient with migraine? So first of all, acute attacks are dealt with NSAIDs, meaning the non-steroidal anti-inflammatory drugs, triptans, and dihydroergotamines. Okay, dihydroergotamines. That's what it is. So for acute treatments, that's what you use. For prophylaxis, what you use is you have lifestyle changes. You can also use beta blockers, amitriptylines, topiramate, valproate. Okay, and so the most important thing over here, okay, the most important thing for over here for solving UWorld is basically the acute treatments. Acute treatments are NSAID, triptans, and dihydroergotamines. That's what it is, dihydroergotamines. And out of the prophylactic treatment, they would like to hear about your knowledge of knowing whether you can use beta blockers for treating migraines or not, and that's what it is. So you can use beta blockers. Okay, and along with that, that's all you need for your questions in UWorld. Do we have any questions regarding migraines? Do we have any questions regarding migraines? Are you guys well acquainted with the treatment of migraine? Because this is a very common topic for your bachelors of medicine and bachelors of surgery. Okay, because this is a very discussed topic in your bachelor degree. Okay, migraines, headaches, tension headaches. So if you guys are well acquainted with these topics, I do not want to go any deeper. Okay, there are more important topics that we should focus on. Okay, next one is a very common one, tension headaches. Okay, so these are the type of headaches which each and every one of you will get right before your exam. Hopefully you guys will not get that. Okay, but some of you might. If you do, there's nothing to be worried about. There's nothing to be worried about. Okay, tension headaches are very common and they usually rise from stress. Okay, and they are bilateral, meaning that they will be present in they will be present in both sides, and they will usually last for more than half an hour and stay till 4 to 6 hours. And and these are the most common type of headaches, and we treat the common headaches with NSAIDs, acetaminophen, okay, analgesics. Okay, we use Tylenol, this, that. Okay, we have a lot of medications for our normal headaches, and this is just a normal headache, tension headaches, and these are basically band-like in pain. So it's as if the patient has a very strong band which is pressing against the patient's head, and I'm pretty sure you guys have experienced this, every one of you, that tension headache. That's what it is. And the most important thing is you can differentiate tension headache from migraine by the absence of aura or photophobia or phonophobia, meaning the patient has no pain no pain, or well, I mean the pain does not increase in exposure to excessive light or excessive sound. That's what it is. Okay, so these are tension headaches. Okay, so that's what it is. Okay, next one. Next ones are the next important type of headaches, which we already discussed about, were the headaches of subarachnoid hemorrhage. We talked about this, that it's a thunderclap headache. Okay, it's as if there's a thunderstorm or there's a thunderclap going in your head, because that will be the worst headache of your life. That is subarachnoid hemorrhage, and the reason is the rupture of aneurysms. Right? We talked about this. And another causes are meningitis. We talked about that too. That in an infection, you get headaches, and we also talked about the fact about large vessel vasculitis, that in temporal arteritis you get the formations of these type of headaches. Okay, so that's what it is. And then in trigeminal neuralgia, that is another condition in which the patient has shooting shock-like pain in the distribution of CN5. Okay, and and the thing is, even migraines are occurring due to irritations of the trigeminal nerve. Okay, and in trigeminal neuralgia, the way that you can differentiate the trigeminal neuralgia from migraine is, the patients of trigeminal neuralgia, their headaches will increase even if you touch a certain part of the face. If the patient starts talking, if the patient starts chewing, basically if the patient moves their mouth, the patient will have increase of headaches, and that will not happen in a patient with a migraine. Okay, in migraine, movements of the face will not increase or decrease the pain. That's what it is. Okay, and the treatment for trigeminal neuralgia is the one where we already talked about. We talked about the fact that how carbamazepine is used for the treatment of trigeminal neuralgia. Okay. Okay, so quick revision. So you have a patient who comes to you with unilateral periorbital pain, lacrimation, rhinorrhea. What is the type of headache that you are dealing with? Fast answers, please. Cluster headache. You have a patient who has come to you with unilateral pain. Along with that, the patient has photophobia, phonophobia, flashing lights, zigzag sounds, smell, migraine. You have a patient who has their exam, who has their USMLE exam tomorrow, and now the patient has extreme bad headache, tension headache. You have a patient who has come to you with severe headache, vomiting, and the patient is complaining of the worst headache of their life. They have never had these type of headaches, and they've never heard of anyone having these type of headaches, subarachnoid hemorrhage. If you have a patient who has come to you with shooting unilateral pain, and the pain increases every time the patient talks, what is the name of this headache? Trigeminal neuralgia. Very good. Trigeminal neuralgia. If you have a patient who has come to you with headache, along with that, the patient has signs symptoms of polymyalgia rheumatica or joint pains. What is the type of headache? Giant cell arteritis. Okay. Okay. So you guys are doing extremely well. Did you guys realize how easy it was for you to do differentiate all the types of headaches? Okay, good. Okay, so that's good. So that was our goal. Our goal was to make it extremely easy for you so that you can diagnose and differentiate all the types of headaches for your purpose of doing well in USMLE, and also for the purpose of you doing well in your practical career. Okay, so will you guys have any difficulties in diagnosing headaches in the future? Okay, hopefully not. Okay, there is another type of headache which you guys are, I'm pretty sure you guys are familiar with. You have They have not mentioned this. It's a sinus headache. Sinus headache. Okay, have you guys heard of sinus headache or sinusitis? Okay, okay. So keep that in mind too. That the USMLE also has their ways of asking you about sinusitis and sinus headache, and the way that they will do that is they will tell you that the patient has pain, rhinorrhea, and the patient has heaviness in the face. Okay, the patient has heaviness or tenderness in the face. If you try to percuss on the maxillary sinus, the patient will have pain. And if you have these type of patients who with which the patients are complaining with, then the condition is known as sinus headache or sinusitis. Okay, that's what it is. Okay, next one. Next one is your movement disorders. Okay, and we would be discussing about this. Okay, we will be discussing about this in a very different way. Okay, and this is an extremely important one. Okay. Okay, what we would be doing is we would be discussing about this, or at the same time, we would be watching some videos so that so that your knowledge about the movement disorders are completely incorporated in your mind, just as the same as your knowledge about headaches. Just give me a minute, please, while this thing comes on. Okay, that's what it is. Okay. Okay, next one. Okay. So the first movement disorder that we will be talking about, okay, the first movement disorder that we will be talking about is akathisia. Akathisia. Okay, the first movement disorder that we will be talking about is akathisia or akathisia. Okay, that's what it is. So it regardless of the pronunciations, akathisia or akathisia is basically a restlessness or intense urge to move. Okay, this could be restlessness or increased urge to move. So basically we have a friend called Kathy. Okay. Okay, so you have a friend, or we have a friend called Kathy, and the problem with Kathy is the Kathy was previously diagnosed with Parkinsonism. Okay, so Kathy was previously diagnosed with Parkinsonism, and right now the problem with Kathy was after being diagnosed with Parkinsonism, that he was treated with anti-Parkinsonism drug, and after being treated with anti-Parkinsonism drug, we know that these drugs work in the dopaminergic pathways, the mesolimbic, mesocortical, the nigrostriatal pathway, right? The nigrostriatal pathway is important for the extrapyramidal symptoms. And what this did was this disrupted the dopaminergic pathway in her system, and this resulted in her increased restlessness and increased urge to move. So our first friend over here, Kathy, okay, Kathy for akathisia, Kathy, okay, so what is her problem? Her problem is she is restless and she has an increased urge to move. So akathisia, okay. One second. Once we show you how the patient look, everything would be easy. Okay. Akathisia is an intense inner restlessness that is okay. Okay. So do you realize that this patient is moving for no absolutely no reason, and the patient is restless? Okay, the patient has an intense urge to move, and the urge is extremely intense. And this is the, for example, this is okay. Okay, so this is very, very upsetting. This is very sad. So this is akathisia. Okay. Did you guys realize what akathisia is? Increased restlessness or increased urge to move. Okay. And our friend Kathy, who was being treated for Parkinsonism, now she has these type of conditions. Are we clear on akathisia? Okay. Okay, good question. How do you differentiate from restless leg syndrome? And we will be coming to that. Don't worry. That is a very important UL question. Okay, we will be discussing about this at the end of all the movement disorders. But have you understood akathisia? Okay, good, good. Okay, next one. Next one is what we will be going is we would be talking about asterixis. Asterixis. Okay. So basically asterixis is basically your extensions of the wrist. Okay. So you have this you have this wrist over here. And what would happen with asterixis is when you ask the patient, okay, when you ask the patient to extend their wrist. Okay. So let's say that this is the patient hand like this. And when you ask the patient to extend, meaning move the feet head in this way, and if the patient, let's say, now has let's say that this is the patient's hands, and you have asked the patient to extend their wrist. Okay, this is the patient's hand. The patient will have flapping movement of the hand. This will result in a flapping tremor. Have you guys ever seen a patient with flapping tremor in your ward, in your medicine ward? Anyone? Okay, good. Okay, perfect. Okay, by now you guys have seen a patient with flapping tremors in the medicine ward. So these patients of your what problem? What was the usual problem for these patients? Why did they have flapping tremor, or what was the indication? What do you suspect? Very good, hepatic encephalopathy or cephalopathy. That's what it is. So that's what happens in a patient with hepatic encephalopathy, or for example, in other metabolic disorders, or even in a disease called Wilson's disease. Okay, I'm pretty sure we have discussed about Wilson's disease, and what do we call Wilson's disease? What do we call Wilson's disease in our lecture? Once again, 13 disease. That's okay. We call it the 13 disease because it's associated with abnormality of chromosome number 30. So that's what it is. So if you have a patient with flapping tremor, okay, if you have a patient with flapping tremor, what you see is you diagnose the patient as hepatic and encephalopathy. That's what it is. Okay, so that's what it is. So let's just look at the flapping tremor video very quickly, so to see if we have understood.
This video will introduce you to opiate extended. They're extending them almost like a.
Okay. So if you ask the patient to extend their hands like this, okay, if you ask the patient to please, let's say you ask the patients that, please, sir, can I ask you to extend your arms, okay, and just keep it out for me. And then if this is what they do, then the
It looks
movement will be like
almost
this,
like
okay, the movements will be like this, okay. So they will have difficulty in keeping their hands focused or straight. And this movement is known as flapping tremor. Okay, good. So I'm pretty sure you guys have understood this. Next one. Next one is athetosis. Athetosis, okay. Next one is athetosis. And what is athetosis? Athetosis is basically a slow snake-like, okay? So if you can think about the vibrations of the hands, okay, these are very slow snake-like writhing movements. And the thing is, these athetotic patients, they have the damage of the basal ganglia. Okay, they have the damage of the basal ganglia. And we know what the basal ganglia is. The basal ganglia has its direct pathway and indirect pathway. And if there are no proper coordinations in between these pathways, then the patient gets a very slow writhing movements. And these slow writhing movements are known as athetosis. Okay, very quickly, what we are going to do is we are going to show you the movements of athetosis. That's what it is. Okay. Okay, once again, let's start. Okay. Okay, so do you see how the movement is very snake-like and slow? Okay. Okay. Okay, so do you guys get the idea of athetosis? Did you guys understand the movement of athetosis? Okay, okay. Is the video helping you guys, or is it? Do you guys think that the video is wasting your time? Okay, the videos are important because I will only show you guys this video once, okay, or you only need to see the video once in order to remember, because you have to realize that we are not studying medicine just for the purpose of solving UWorld question or for the purpose of doing well in our USMLE step one. The basic reason why we all want to be physicians is because we want to help people. And how can you help people if you don't understand how a certain condition looks like, right? So I'm pretty sure you guys will appreciate the fact of looking at the videos, because you guys will only have to see the videos once. I do not expect you guys to go and see this video once again when you guys go and read the first aid once again. Okay, so please just bear with us and just watch the video. Okay, next one. Next one is okay. Next one is chorea. Okay, next one is chorea, and I'm pretty sure what you guys have heard chorea before. Chorea is again another lesion of the basal ganglia, and chorea. I am pretty sure I showed you the choreatic movement, and I will show you it once again. It's a sudden, jerky, purposeless movement. So you have flappings of hands, which are seen in a patient with Huntington disease. In Huntington disease, this is a very degenerating disorder in which you have degenerations of basal ganglia. Okay, and what you have is you have this sudden, jerky, purposeless movement, and then the movements are absolutely very, uh, what can I say, very directive of Huntington disease. Along with that, they're also seen in another condition, that is in rheumatic fever. You have a condition that is known as Sydenham chorea. In Sydenham chorea, okay, what you see is you have this movement of the hands. Along with that, you also have wild movements of the tongue. And I'm pretty sure you guys have heard about Sydenham chorea in acute rheumatic fever. Can I ask you about some of the other things that can also be seen in a patient alongside Sydenham chorea in acute rheumatic fever? What are the other things that you can see in a patient with acute rheumatic fever? Subcutaneous nodules, then migratory polyarthritis, and what else? Do you guys remember that we have some major signs and minor signs of acute rheumatic fever? Erythema nodosum, very good. Pericarditis. Okay, so that's what it is. Okay, okay, good. So, and along with that, if the patient also has or if the patient also has Sydenham chorea, then the patient can be diagnosed with acute rheumatic fever. Okay, with that being said, let's watch a video on chorea. Okay, let's see how choreatic movement is. Okay, let's wait for this ad to end. Okay, it's extremely annoying. Okay.
হতে পারে ইনভলান্টারি কি হলো না তোমাকে সেটা করতে
Okay. Okay, so look at this arm over here. Okay, look at the arm of this young patient over here. Okay, so there is purposeless movement or flinging of this arm. Okay, okay. So this is what a chorea looks like. So have you guys understood chorea? Okay. So what is the name of the condition if which our friend Kathy has, in which she has the sudden urge to move, restlessness, she's restless, she has a sudden urge to move. What is the name of the condition? Akathisia. Okay, because Kathy has Kathy had Parkinsonism, so that's what it is, akathisia. Okay, next one. Next one is if you have a patient with hepatic encephalopathy and another patient has wild movements of the hands, what is the name of this condition? Asterixis or flapping fingers. If you have a patient who slow snake-like writhing movements, and what is the name of this condition? Athetosis. If the patient has wild flinging of the hands, if the patient has wild flinging of the hands, what is the name of this condition? Okay. Next one. Next one is dystonia. Okay, dystonia. I'm pretty sure you guys will see dystonia in your emergency department if you work over there. Dystonia is basically a sustained involuntary muscle contraction, meaning that the muscle has been contracted and the muscle is dystonic. Okay, and this is a very common condition. This is basically the same as spasm, but the thing about dystonia is that dystonias are worse than spasms. So that's what it is. So basically, what is dystonia? Dystonia is basically torticollis. We talked about torticollis in our last UL lecture. This could also be blepharospasm or writer's cramp. So that's what it is. And how do you treat a patient with dystonia? What you use is you use botulinum toxin, and we all know how botulinum toxin works. How does botulinum toxin work? Well, once again, does anyone have any idea? Botulinum toxin. Does it increase or decrease the secretion of acetylcholine or activity of acetylcholine? No. degrees. That's what it is. Okay, so that's what it is. And so that's how botulinum toxin works. Can anyone tell me one esophageal disorder in which we use botulinum toxin? Esophageal disorder in which we use botulinum toxin, actually. Okay, good, very good. Okay, so that's what it is. Okay, so I will not go into details about how dystonia look. I'm pretty sure you guys know. So I'm pretty sure you guys can paint a picture in your head about how dystonia would look like. Okay, so I will not go into any more details. Next one is essential tremor. Essential tremor is basically high frequency tremor. And the thing about essential tremor is, so you will see a lot of this because this is extremely common and this is extremely high yield because what happens with essential tremor is when a patient is anxious. Okay, so let's say you are, let's say, do you pretty sure, do you guys remember the time when you guys were really anxious about something, and let's say you guys were afraid or anxious, and then suddenly you looked at your hands and you were so scared that your hands were shaking. Okay, so that condition of yours, my friend, is essential tremor. That's what it is. And the problem is this could either be familial, or the what happens is if that type of tremor gets if you experience that type of episode for a long period of time, that is known as essential tremor. And the patients, what they do is they know they have this condition, so what they do is they self-medicate themselves with either alcohol. Okay, they self-medicate themselves either with alcohol or or what they do is they get professional help, and if they come to a physician, the physician usually treats it with a beta blocker. Okay, because the main problem with essential tremor is anxiousness. So they try to treat the patients with essential tremor with anxiousness. So how will you receive questions about essential tremor? You will receive questions about essential tremor by the fact that there is a movement disorder preceded by a feeling of anxiousness or scared, or some sort of some sort of an upper type of emotion. That's what it is. Okay, so patients will not get tremor if they're resting or if they're calm, if they're having fun. These type of tremors will not happen then. They will only happen when the patient is anxious, scared, or there's something wrong with their life. Okay, so that's what it is. Okay, so essential tremor, that's what it is. Next one is intention tremor. Now this is different. Okay, intention tremor is slow zigzag motion when pointing towards a target, and you have to see a video on intention tremor. Okay, so this usually happens when the patient intends to move their hand. When the patient intends to move their hand. So let's say this tremors will not happen by themselves, but when you ask the patient to move their hand, okay, look. So this patient was asked to move the hand, and when the patient moved the hand, look, this is known as intention tremor, that the patient cannot stay steady. Okay, okay. Keep in mind that these type of movements are not happening in these patients in this arm, in which the patient has not been asked to move this arm. Okay, so this type of tremors are not happening in this patient. But if this same patient was anxious or afraid or scared, then you will see that this arm was also moving. That there is also tremors are happening in this arm, and that tremor is known as essential tremor. If since the patient was asked to move this arm only, okay, then since the patient was asked to extend this arm, that is the reason why the patient started experiencing tremor in this arm, and this is known as intention tremor. And the reason for which the patient get intention tremor is because of a cerebellar dysfunction. Is because of a cerebellar dysfunction. That's what it is. Okay, that's that. Next one is a resting tremor. Okay, next one is a resting tremor. Okay, so before I move on to resting tremor, have you guys understood all the movements that till now that I talked about? Do we have any confusion? Once again, before moving forward, fast questions and fast answers, please. Okay. So restless and intense urge to move. What is the name of this tremor? Restless and intense urge to move. I will repeat core once again. Okay, no problem. Restless and intense urge to move. Fast hands, please. Next one is extension of wrist on flapping motion. Extension of wrist and flapping motion after exercise. Slow snake-like writhing movements. So snake-like writhing movements at the doses. Next one is chorea. Okay, so we have Dr. Garbasi who wanted to repeat chorea. Okay, chorea is basically sudden, jerky, purposeless movement. Okay, sudden, jerky, purposeless movement. So that is chorea. Okay, chorea is sudden, jerky, purposeless movement. Okay, so okay, we talked about chorea. Okay, once again, let's show this picture. Okay, there's another one. Okay, so for purpose of making Dr. Krabasi understand. Okay, so look at this hand of this little girl again, Dr. Krabasi. If you can see that this girl has sudden, purposeless movements of her hands, and these type of movements are known as choreatic movements due to lesions of the basal ganglia. Are we clear right now? Are we clear about chorea? Okay, good. Next one. What is the name of the condition if the patient has if the patient has sustained involuntary movements of the muscle with contraction? Sustained involuntary muscle contraction. Okay, next one. Next one is if the patient has zigzag motions of the finger only when the patient was asked to move the finger. What is the name of this condition? Intention tremor. What is the name of the condition in which the patient has tremors when the patient is anxious, afraid, scared, excited? Intention tremor. Sorry, essential tremor. As essential tremor. My bad. Essential tremor. Yeah, okay, that's what it is. Essential tremor. Next one. Next one is a resting tremor. Resting tremor is basically uncontrolled movement of the appendages, mostly meaning by that hands. Okay, and what's happening with the resting tremor is that with resting tremor, the patients have the movements of the hand at rest, and this usually happens in a condition that is a Parkinson's disease, and the disruption is due to disruption of the substantia nigra. Okay, due to the disruption of substantia nigra, the patient has resting tremor. Okay, and we know that for in order for Parkinsonism to occur, that substantia nigra is important for which pathway, the direct pathway or the indirect pathway of the basal ganglia. Once again, can I get some fast answers? Indirect or direct? Indirect pathway. Okay, so if you have disruptions of the substantia nigra, okay, the pathway of the indirect pathway will not work. And indirect pathway, is it used for increasing motion or decreasing motion? Indirect pathway. Increase motion. If the indirect pathway, will there be increased motion or decreased motion? If the indirect pathway does not work, will there be increased motion or decreased motion? Increased motion, that is correct. Indirect pathway decreases your motion. So if the indirect pathway does not work, there will not be any decrease in the motion. Hence, there will be increase in motion. And if this increase in motion is basically a reason for the occurrence of resting tremor, that's what it is. Okay, so resting tremor, and this is known as a pill rolling tremor. Okay, this is what you guys have to see. Okay, yeah, resting tremor, pill rolling tremor. Okay.
In the following video.
Okay, so this is known as a pill rolling tremor. Okay, so this looks like as if the patient is shaking a bottle of pills. Okay, so pill rolling, that's what it is. Okay. Okay. Are we clear on resting tremor? Yes, no? Oh, good. Next one. Next one is hemibellissimus. Hemibellissimus. Hemibellissimus is wild flailing of one side of the body, and the damage is due to contralateral subthalamic nucleus. Once again, subthalamic nucleus. Which one is this used for, direct or indirect pathway of the basal ganglia, or for both? Both? Are you guys sure it's used for both or just the indirect pathway? Which one? Okay, so that's what it is. Okay, so if you have damage of the subthalamic nucleus, okay, so what would happen is, once again, if it is used for, if so, since it's mostly used for your indirect pathways, right? Okay, since it's mostly used for your indirect pathways, to some extent, it's also used in the direct pathway too. But the thing is, since it's very most important for indirect pathway, if you have damage of the subthalamic nucleus, will there be less movement or more movement? Will there be less movement or more movement? Why will there be more movement? Why will the movement be increased? Because fast answers, please. I'm pretty sure one of you guys will figure out why will the movement increase if you have damage of the subthalamic nucleus, because we talked about, there we go, damage of the indirect pathway, as simple as that. And the indirect pathway is used for decreasing your motions. Again, if the indirect pathway is used for decreasing your motion, if the indirect pathway does not work, then there will be excessive movement. That's what it is. So thank you so much, doctors, for mentioning that. That's what it is. That's exactly what's occurring with hemibellismus. And with hemipellismus, okay, this is exactly, you guys have to see this because this is very particular. Okay, hemipellismus. Okay, one second. Okay, this is a proper video. Okay. So, okay, so this poor lady over here, she has, what does she have? She have the sudden, wild flailing of one side of the body. Okay. Okay, so do you see this flailing movement of the arms? Okay, and it's completely purposeless, and she has no idea. There's no way she can control it because her brain is sending signals to the basal ganglia. But due to the fact that her subthalamic nucleus is damaged, okay, her inhibition, her indirect pathway is not working properly. As a result, what's happening is her motions are not decreasing. So that's what it is. So this type is known as hemibellismus. Okay. Okay. So half body dancing. Basically, that's what it is. Okay. So are we clear on hemibellismus? Okay. Okay. Once again, if you have athetosis, which part of the brain is damaged? Athetosis. If you have chorea, which part of the brain is damaged? Okay. If you have intention tremor, which part of the brain is damaged? Okay, if you have tremor, which part of the brain is damaged? Okay, if you have hemibellismus, which part of the brain is damaged? Okay, if you have a patient who comes to you with fusion of basal ganglia and monoventricle, what is the name of the diagnosis? Fusion of basal ganglia and monoventricles. What is the name of the diagnosis? Very good. I just wanted to test you guys to see if you guys can remember holoprosencephaly, and this has nothing with this. Okay, this has nothing to do with the tremor. Just wanted to see how smart you guys are, and you guys are extremely smart. So thank you so much for remembering the previous lectures. Okay, so that's what it is. The holoprosencephaly is what it is. Okay, so what do we see in a patient with holoprosencephaly? There is a midline defect. You have cleft lip, cleft palate, proboscis, cyclopia, and the condition is due to when you do a CT scan, you see a monoventricle and fusions of basal ganglia. Okay, hopefully none of you guys will have problems with uh, diagnosing diagnosing holoprosencephaly in your USMLE U world. Okay, next one. Next one is myoclonus. What is myoclonus? Myoclonus are basically sudden, brief, uncontrolled muscle contraction. We talked about myoclonus at the back, and the most common diagnosis is it's usually due to a metabolic abnormality, such as a renal or a liver failure. That's what myoclonus is. Okay, and I'm not going to show you guys any videos because I'm pretty sure you guys can diagnose myoclonus. Okay, next one. Next one is restless leg syndrome, and we had one physician who wanted to know about restless leg syndrome. Okay, what is restless leg syndrome? Restless leg syndrome is basically um, the um, the sudden urge to move your legs excessively. Okay, and the best way you can diagnose or differentiate restless leg syndrome from any type of tremor, for example, essential tremor, is that these syndromes will increase worse, and these syndromes will increase, and they will be worse at rest, or they will increase more at night. Okay, and why is this happening? This is usually due to an iron deficiency or due to a chronic kidney disease, and that's what it is. Okay, so before we go on to that, okay, one second. Okay, restless leg syndrome. Okay, enough for the ads. One second, please. Okay. Okay, perfect. So over here, look, this patient. Okay. Okay. Okay, so it's this movement that you just witnessed over here with the patient being asleep and this intense urge for the patient to move, and look at the changes of the EEGs, okay? So that's what it is. So this type of movement that the patient is experiencing is known as restless leg syndrome. And once again, the best way to diagnose restless leg syndrome is these syndromes are more worse at rest, or they're worse at nighttime. So that's what it is. Okay. And they're associated with iron deficiencies. And how do you treat a patient with restless leg syndrome? You use dopamine agonists, dopamine agonists, for example, like pramipexole or ropinirole, and that's what it is. So you use dopamine agonists such as pramipexole and ropinirole. So you treat the patient with more dopamine. So that's what it is. Okay. Okay. Once again, so what we will do is, well, I would expect one physician to, okay, no, not one physician, two or three physicians, if they're confident, to answer just the names of the movement disorders, and I will divide the presentations. Okay. So we once again, presentations are your questions and the movement disorders are your answers. So if you have to test yourself, test in this way, okay? Cover this part with your hand and read this part and see whether you can remember the names, okay? Don't read the names and try to see whether you remember the presentations, because the presentations will be present in your question, okay? So you will be questioned about the presentations and you will be tested on the answers, okay? So this is your answer, this is your question, okay? So that's what I will do. I will tell you guys a presentation and then I will ask you guys the name of the disorder. Okay, so I would need the help of three physicians. So any one of you three guys, please, if you're kind enough to help us out. Dr. Iman, who else? Who else? Dr. Hussam, our friend. Okay. Dr. Karbasi. Okay. And we also have Dr. Samra Hussain. Okay, so that's good. Okay, so let's start with Dr. Hussain, who said yes first. So Dr. Hussain, would you be kind enough to unmute yourselves and answer the questions, please? Um, Okay,
Yeah,
so first question is, what is the name of the disorder in which the patient has extension of wrist causing flapping motion?
extension, slap, astraxis,
Very good. What is the name of the condition in which the patient has slow snake-like writhing movements of the finger?
acetosis,
Athetosis.
uh,
Very good.
acidosis, yeah,
What is the name of the condition of our friend Kathy, who has restlessness and intense urge to move?
akathisia,
Okay, and what is the disorder associated, I mean, the disease associated with akathisia?
disease, Parkinson,
Very good. That's what
akathisia,
our friend Kathy
yeah,
has. Last question for you
yeah,
is, what is the name of sudden, jerky, purposeless movement? What is the name of the disorder?
Korea,
Very good, Korea.
Korea,
Thank you so much, Dr.
welcome.
Next one is
Thank you.
Dr. Iman. You are welcome. Okay, the next one is Dr. Iman. Dr. Iman, would you be kind enough to unmute yourselves and
Yes.
answer the questions? Okay. So first of all, what is the name of the condition in which the patient has sudden involuntary muscular contractions? Sustained involuntary muscular contractions.
Dystonia.
Okay, very good. What is the name of the tremors, which usually happens when the patient is anxious or afraid or excited?
Essential tremor.
Very good. What is the name of the condition in which the patient has, okay, in which the patient has movements of the finger when the patient is asked to move towards a target?
Intention tremor.
Very good. Okay, thank you so much, Dr. Iman. Now we will go to our friend, Dr. Hossam. Dr. Hossam, can you hear my voice?
Yes, doctor.
Okay, very good. So what is the name of the condition? Would you be kind enough to tell us the name of the condition in which there is uncontrolled movement of the hand, and this is usually occurring in a patient with Parkinsonism at rest?
Resting tremor.
Okay, good. What is the name of the disorder in which the patient has wild flailing of one side of the body?
Hemiplegismus.
Very good. Okay, thank you, Dr. Hussam. Next one goes to our friend, Dr. Karbasi over here. Okay, would you be kind enough to tell us? Yes, would you be kind enough to tell us what is the name of the condition in which the patient has sudden, brief, uncontrolled muscular contractions?
Myoclonus.
Very good. What is the name of the condition of the patient in which the patient has an intense urge to move their legs, especially at night?
Rest leg syndrome.
Okay, how do you treat a patient with restless leg syndrome?
Dopamine agonist, pramipexole, for example.
Okay, what is the name of the condition in which the patient has restlessness and intense urge to move?
Akathisia.
Very good. Okay, that's good. So thank you so much, Dr. Karbasi, for performing.
Thank you. You're welcome.
That's what it is. Okay, so basically that's how you will be asked about the question. Do we have any more confusion or lack of confidence regarding the movement disorders? Anyone? Okay, good. So if you ask me which one of these are, yes, can you just what? Yes, okay. Show again how they ask. Okay. How they ask questions is basically they will have questions from the presentation. They will tell you have a patient who has entered with restlessness and intense urge to move, and they will ask you what the diagnosis is, and they will see whether you have the proper knowledge to differentiate akathisia from, let's say, essential tremor, chorea, and athetosis. Okay, and most of the time, the patient, I mean, the students, they remember the presentations, but they forget whether the name was akathisia or whether the name was athetosis. Okay, because the names are extremely similar and very confusing. So that's why for akathisia, I used Kathy. Okay, so remember Kathy because akathisia is the one which they ask a lot. Okay, so they try to confuse you with akathisia and athetosis. So that's what it is. Always remember Kathy is the one with Parkinsonism, and the Kathy has restlessness and intense urge to move. Okay, if you ask me how important are these things over here, number one, akathisia is put your stars, put 2 stars akathisia. Okay, 2 stars for akathisia. Okay, asterisk is 1 star, athetosis 2 stars. Okay, chorea 3 stars, chorea 3 stars. Okay, dystonia 1 star. Okay, essential tremor, that's okay. Essential tremor, not that high. Oh, okay, essential tremor is important too. I remember I received a lot of questions. 2 stars. Intention tremor, that's okay. Resting tremor, only question I received about resting tremor. Okay, hemibellismus, 1 question or 1 or 2 at max. Restless leg syndrome, 1 question. That's what it is. Okay, so that's that. Okay, so between chorea and hemibellismus, when I saw the videos in hemibellismus and the movement was fast, but we say dancing. Okay, so chorea versus hemibellismus. Okay, so this is a good question. So what is chorea? So how can you differentiate chorea by hemibellismus? Chorea is basically purposeless movement, sudden, jerky, purposeless movement. But in chorea, you will not have flailing of the hand. What you mean by flailing is, let's say this is the patient, that is the patient's hands, okay? Chorea will happen over here, okay? They will keep on moving, but like this. If you have hemibellismus, what you will have is, you will have the patient's hands, and the hands will just move all the way over here. And these hands will go over there. This feet will go over here. This feet will go over there. And this will known as flailing, okay? This type of movements is known as hemibellismus. And that's how you can differentiate chorea with hemibellismus or one-sided dancing. Okay. Okay, so that's what it is. Okay, so would you guys, are you guys exhausted? Would you guys be willing to take a short break or keep on moving on? Okay. Great. Okay. Okay, so before we take a break, once again, okay, once again, keep in mind that we are taking a little bit of time to finish neurology, okay, because neurology is important. Okay, this is one of the, so the thing is that you have in your USMLE step one, pathology is basically 50% of your whole exam, 50 to 52%. And out of pathology, out of those 50 to 52%, close to around 20 to 22% of the questions are from neurology. Okay, so that's what it is. So neurology is very important. Every block in your U world, I mean your USMLE step one, you will receive questions about neurology. Okay, so that's that. So that's why we're taking a little bit of time. Okay, that's that. And another thing is we see a lot of students over here, okay, who has failed in completing their transactions, and also failed in letting us know about the extensions which they have needed, or regardless of their emails or completions of transactions. We have the lectures here for you, because to be honest, we do not want to stop the lectures just for the fact that we did not receive emails about your extension or completion of transactions, because that's not how we are. Okay, but at the same time, please, if you need extensions to complete your transactions, if you could just please let us know, we would highly appreciate it, because it would allow us to keep our student format in place. And at the same time, if you can please complete your transactions, let's say by tomorrow, that we would also highly appreciate it, because at the same time, we cannot keep on providing the lectures to each and everyone. Okay, and so that's that. So if you need any help regarding the completion of transactions, please let us know. If you need extensions, please let us know. We would be more than happy to provide you extensions. But if we do not see emails from you guys after today's lectures, then unfortunately we will fail in providing you the lectures or the videos for this week. So that's what it is. And I do not want to lose any one of our students. If you have any issues with our lecture which you need us to improve or focus, please let us know. That's what it is. Okay, but at the same time, we would highly appreciate if we can work together. Okay, that's what it is. So all the students who has completed their transactions, okay, we have not sent them any emails. Okay, and everyone who has completed the transaction has completed the transaction. That's what it is. Okay, so you guys have nothing to worry about. If anyone is left from over here, okay, so please try to complete your transactions by today, so we can send you guys the URLs for tomorrow. Okay, having said that, let's take our break for right now. How long do you guys want to take the break? 10 minutes or 15 minutes? 10 minutes. 10 minutes. Okay. Okay, 10 minutes sound good. Okay, so we will be back here exactly around 11:25. Okay. Okay, so is everyone back from their break? Is everyone back from their break? Oh, good. Okay, let's wait for a little bit longer for everyone else to come. After that, we can start with our neurodegenerative disorders. Okay, good. So we have everyone who is back from their break. Okay, good. So far, are you guys understanding neurology? Are you guys confident with neurology? Everyone? Confident with neurology? Okay. Do you guys remember the story about our three brothers, who was a professional, who used to roam around, and one brother who kept on messing up? Okay. What did the professional do? What did the professional do? Telephones and dies. Very good. What did the good? What did the brother who kept on messing do? He always kept on messing up. What was the problem with the younger brother who kept on roaming up, who kept on roaming? Met someone and meet and mate. That's what it is, meet and mate. So with that, we have prosencephalon, then mesencephalon, then we have rhombencephalon, right? Okay. And then, so what are the derivatives of prosencephalon? What are the derivatives of prosencephalon? Telencephalon. And what are the derivatives of mesencephalon? What is the derivative of mesencephalon? Okay, what derivatives of rhombencephalon? Rhombencephalon. Okay. Okay, so the reason why I asked you guys is because this was from our first lecture. Okay, so if you guys can remember what we talked about from the beginning of our first lectures, I'm pretty sure you guys can remember all the things that we discussed from the first lecture of neurology till now. So are we confident on neurology? Are we neurology? Okay, good. Okay, so with that being said, let's start with our next discussion, that is neurodegenerating disorders. Okay, so we will talk about neurodegenerative disorders. That's what it is. Okay, so what will we talk about is basically what we talk about the fact that we have a couple of neurodegenerative disorders that we have to differentiate. Okay, that we have to differentiate, and UWorld has its ways of asking questions about neurodegenerative disorders. And basically, to be honest, this is extremely easy, and this is very important for you to increase your marks in UWorld. I mean, in your USMLE. But because if you can differentiate all the different types of diseases, you can easily diagnose the disease, and this will help you in increasing your marks very easily if you have mastered it. And we assure you that at the end of today's lecture, you will have mastered it. Okay, so the first disease that we will be talking about is Parkinsonism. But before we do that, let's talk a little bit about what neurodegenerative disorders are. These are basically degenerations of the neurons. Okay, so we have neurons in the brains, and if there's degenerations of the neuron, this is a neurodegenerative disorder. And basically, this will result in decrease in cognitive ability, memory, or function. So patients will have decrease in cognitive ability, memory, or function with intact consciousness, meaning that the consciousness will be intact. So what is the problem? You will be degenerating your neurons, and we know that the neurons are important for proper functioning of the brain, right? And there are different areas of the brain which are involved for different types of functions. So depending on which part of the brain the degeneration is taking place, the signs and symptoms of the patients will be accordingly. That's what it is. Okay. So in a majority of degenerative disorders, you get dementia. Okay, basically dementia means in broad spectrum, what the dementia could mean is loss of memories. Okay, and some of the reversible causes of dementias are basically hypothyroidism, vitamin B12 deficiency, neurosyphilis, and normal pressure hydrocephalus. Okay, we will just keep these things in mind. Okay, now we will be talking about them in details. And we have already talked about hypothyroidism, vitamin B12 deficiency in our previous lecture. We have not talked about neurosyphilis as of yet. We will talk about it, and normal pressure hydrocephalus. We will also talk about this in the future. So basically, what is neurodegenerative disorder? Degenerations of the neuron resulting in decrease in cognitive ability and ability of the memory or function. That's what it is. The first one that we will be talking about is Parkinsonism. Okay, so what is Parkinsonism? Parkinsonism, what basically is this is basically your loss of dopaminergic neurons. So basically, the dopamine neurons which are present in the substantia nigra pars compacta. Okay, so how many types of substantia nigra do we have? Substantia nigra pars compacta and substantia nigra pars. Anyone? How many types of substantia nigra do we have? Substantia nigra pars compacta, substantia nigra pars reticulata or reticularis. That's what it is. So Parkinsonism is the problem with the loss of dopaminergic neurons in substantia nigra pars compacta. That's what it is. Okay. And what would happen is you have what happens is in Parkinsonism you have this accumulation of eosinophilic inclusion, meaning that there's inclusion bodies of eosinophilic inclusion substances, right? And these eosinophilic inclusion substances are known as Lewy bodies. Lewy bodies. Lewy bodies are basically they are composed of alpha synuclein. Alpha synucleins are eosinophilic inclusion. These are basically the sign. This is basically the name given for eosinophilic inclusion. And what you can see is these accumulations of Lewy bodies. And these accumulations of Lewy bodies are not only for Parkinsonism. They are also present in other conditions. For example, in Lewy body dementia. Okay, we will be talking about this in a while. So first of all, let's look at this Lewy bodies in case of Parkinsonism. Okay, so this is basically what they are talking about. Okay, so you see these bodies over here. Okay, so you see these eosinophilic inclusion bodies over here. These are known as Lewy bodies. Okay, so that's what it is. And if you see a patient with signs symptoms of tremor, rigidity, and then there's presence of akinesia. I'm pretty sure you guys know about the sign symptoms of Parkinsonism, right? TRAPS. So for TRAPS, we have tremor, rigidity, akinesia, meaning bradykinesia. Okay, the patients will have problems with initiating a movement, postural instability, meaning that their postures will be not stable, shuffling gait, and micrographia. Okay, let's show you a patient of. Okay, let's show you a patient of Parkinsonism. Okay, 1 second. Okay, the internet is acting up once again. 1 second. Okay, let's keep the videos for the last. Okay, since this is going to take a bit more time, let's just finish the thing. But do you have you guys seen any patient with Parkinsonism in your medicine ward? Have you guys seen any patient with Parkinsonism ward? Okay. If you have seen patients with Parkinsonism in your ward, then there is no need to see more videos. You can just visualize what you saw. That's what it is. Okay. Patients will have what will they have? Basically, we showed you the pill rolling tremor, rigidity, akinesia, posturing instability, shuffling gait, and your um, small handwriting, meaning micrographia. And along with that, the patient will have loss of dopaminergic neurons, okay, in the substantia nigra. And there will be accumulations of alpha synuclein. That's what it is. So what is alpha synuclein? I want to talk a little bit about that in detail. So alpha synuclein, this is basically a protein. Okay, this is basically a protein of the function of which is not known. Okay, the function of which is not known, and it is predominantly expressed in certain areas of the brain. Okay, and the usually is these proteins are encoded by a gene. Okay, so we got this knowledge from Firecracker. For the students who have joined our lecture, we use Firecracker for providing extra knowledge. So that's what it is. So if you ever receive a question about synuclein, okay, the okay, what's going on over here? 1 second. The name of this gene is SNCA. SNCA. Okay, SNCA gene. SNCA gene. If there is excessive expression of SNCA gene, okay, you will get formation of these type of proteins. These type of proteins are known as alpha synuclein proteins. And the thing is, alpha synuclein proteins, they are difficult to break down, or they're difficult to degenerate, so they keep on accumulating. And once this keeps on accumulating, this accumulation is known as Lewy bodies. Okay, this accumulation is known as Lewy bodies. Okay, so that's what it is. And along with Parkinsonism, there's also another drug which is known as MPTP. MPTP. It's an illegal drug which is metabolized to another condition that's known as MPP plus. I don't want to go into details about the whole breakdown of MPTP, but this MPP plus, what happens is this MPP plus is toxic to substantia nigra. So this MPP plus accumulates in substantia nigra, and this MPP plus, once it accumulates in the substantia nigra, this comes up with the signs symptoms of Parkinsonism. That's what it is. So tremor, rigidity, akinesia, postural instability, shuffling gait, and micrographia. That's what it is. Okay. So have you guys understood what alpha synuclein is? Have you guys understood what alpha synuclein is? Guys? Okay. Alpha synuclein. Have you guys understood what alpha synuclein is? Okay, once again, alpha synuclein. Alpha synuclein is basically a protein, okay, in which there is eosinophilic inclusions, okay, a protein in which there is eosinophilic inclusion due to overexpression of a gene known as SNCA gene. SNCA gene. And this protein, what it does is it goes and accumulates in different parts of the brains. Okay, it can go and accumulate in the neocortex, in the hippocampus, in the basal ganglia, in the substantia nigra. Okay, and once this keeps on accumulating, this will result in the formation of Lewy bodies. This will result in the formation of Lewy bodies. Okay, are we clear now? Okay. How will this Lewy body look like? This Lewy body will look like something like this. Okay, composed of alpha synuclein. That's what it is. Okay, so these inclusion bodies that you see over here, these are Lewy bodies. That's what it is. Okay, next one. Next one, what we want to talk about is Huntington's disease. Okay, so Huntington's disease is basically okay. Okay, so Huntington disease. What is Huntington disease? This is basically a trinucleotide repeat extension disorder. So what you have is you have a chromosome number 4. So in chromosome number 4, what you have is you have this gene over here, which is HTT. I mean the CAG. Okay. Okay, so it's a trinucleotide repeat. What keeps on happening is the CAG has a repeat exit, so it becomes CAG, okay, and then CAG, okay, and then CAG. That's what's happening over here. So this trinucleotide repeat, it happens in the Huntington gene, and this gene is located in chromosome number 4. Okay, this gene is located on chromosome number 4. So what do we use for our mnemonic? We use for mnemonic that is hunt for a cage. Okay, so hunt for a cage. Okay, so hunt for a cage. Hunt for Huntington disease, 4 for chromosome number 4, and cage for the trinucleotide repeat extension, which is CAG. Please write this down in your book. Okay, you would need this. And what would happen is if you have a patient with these type of trinucleotide repeats, what you will get is you will get onsets of the symptoms such as chorea. We talked about chorea. Then the patients will get athetosis. Okay. Another thing that patients will get is very, very important. That is aggression. Okay. Personality changes. So you will get questions in your UR where they will tell you about an older male who has come to you with onsets of personality changes for a long period of time. That along with this, the patient also has sudden movements of the hands and sudden movements of the arms, which are while lunging. Okay, and if these type of questions arise, the first thing that you have to think about is Huntington's disease. Huntington's disease. Okay, so think about a hunter. Okay, so what does a hunter do? The hunter tries to hunt. Okay, the hunter. So we're talking about a story mnemonic over here. So think about a hunter. What the hunter does is the hunter tries to hunt for let's say a prey, right? And what happens is when the prey starts running away, let's say the hunter is trying to hunt a deer, and when the deer is walking away, the hunter gets very angry. Okay, so that is number one, aggression. And then after that, the hunter starts moving, and then the next one is movement disorders. So two things you have to remember about Huntington disease is number one, aggression. There is aggression or personality changes, and number two, there are movement disorders. Okay, and what is happening over here is you also have atrophy of the caudate and putamen. Okay, so what you have is you have the caudate nuclei and then you have the putamen, which undergoes atrophy. And if you have atrophy of the caudate and the putamen, what happens is the ventricles surrounding these things, they result in compensatory increase in size of the ventricles. And this is known as ex vacuo ventriculomegaly, meaning that the ventricles are not increasing by themselves, but just because of the fact that the surrounding structures are becoming small, the ventricle looks bigger, and this is known as compensatory or ex vacuo ventriculomegaly. That's what it is. So in Huntington disease, you get ex vacuo ventriculomegaly. Okay, so that's that. And the changes that you can expect in a patient with Huntington disease is basically the patients will have increase in dopamine. Okay, the patients will have decrease in GABA and decrease in acetylcholine. So acetylcholine and GABA will decrease. And this makes sense because if GABA is decreased, okay, meaning that why is GABA decreased? If GABA was increased, there will not be excessive movements of the body because GABA is an inhibitory neuron and acetylcholine is also decreasing. So what would happen is over here, the dopamine is increasing, and due to this increased amount of dopamine, which is acting as an excitatory neurotransmitter, there is excessive movements of the body. Okay, so another thing that a hunter was doing. Okay, so what was the name of the hunter? The name of the hunter was Gabe. The name of the hunter was Gabe. Okay, the name of the hunter was Gabe, and was the hunter succeeding in was the hunter winning in getting the prey or losing in getting the prey? Was the hunter winning with hunting or losing with its hunting? Losing. Okay, so what happens to Gabe? Gabe decreased. So Gabe is losing. Gabe is losing. Okay, Gabe decreased. So Gabe or GABA decreases. Okay. Gabe or GABA decreases. Okay. Next one is next one is acetylcholine. Okay, acetylcholine, the mnemonic that we will use, the mnemonic that we use is cold. Okay, so the mnemonic that we will use for acetylcholine is cold. Okay, and if the hunter starts running now behind, if the hunter starts running behind the predator or behind the prey, will the hunter have increase in body temperature or decrease in body temperature? Increase in body temperature or decrease in body temperature if the hunter starts running? Increase in body temperature. So if the hunter has increased body temperature, then there will be decrease in cold. Okay, decrease in cold. This is just a mnemonic. Huntington's disease has nothing to do with thermoregulation. Okay, this is just a mnemonic for you to understand, just in case you forget if the acetylcholine increases or decreases in Huntington's disease. So that's what it is. The decrease in cold meaning that ACH decreases. Okay, ACH decreases. Now, next one is dopamine is a very satisfactory hormone. Okay, so are we well acquainted with the fact that how dopamine is a satisfactory hormone? If you win anything, or if you like doing what you like, your brain secretes a lot of dopamine. Are you guys well aware of that information? Yes, no? Are you guys well aware of the fact that dopamine is the satisfactory or the happy hormone? Okay, so if the hunter starts hunting, and that's what the hunter does, will he be happy or will he be upset? Happy or upset? Happy. If he is happy, then his dopamine is increased. Okay, so dopamine is increased. Now, once again, how did we learn about the mnemonics of Huntington disease? First of all, what was the name of our hunter? Fast answers, please, so that we can move on forward. What was the name of our hunter? Gabe. Was Gabe winning or losing? Gabe winning or losing? Losing. So GABA increase or decrease? So does GABA increase or decrease? GABA decreases. Next, acetylcholine, and the word we used was cold. If the hunter starts running, will he have increase in body temperature or decrease in temperature? Increase in body temperature. As a result, cold decreasing. So will there be a decrease or in acetylcholine or increase in acetylcholine? Decrease. Okay. Now the hunter is happy that the hunter is doing some hunting. Now, what will happen to to the happy hormone? Will there be increased? Dopamine will be increased, or will dopamine decrease? Dopamine. Okay, so as a result, what's happening? Increase in dopamine and decrease in GABA and decrease in acetylcholine. Okay, decrease in acetylcholine. That's exactly what's happening over here. And what was the mnemonic that we used for Huntington disease in terms of making its association with chromosome number? Chromosome number for cage. The hunter was in a cage to put the predator put the prey in. Hunt HTT gene, 4 for chromosome number 4. CAG was for the trinucleotide repeats. CAG was for the trinucleotide repeat. Okay. That's what it is. Okay. But if dopamine is increasing, why is the symptoms with aggression? Okay. So the thing is, dopamine increasing is just the mnemonic we used for remembering the Huntington's criteria. Okay. In Huntington disease, the patients are usually not happy at all. Okay, it's not a very happy disease. The only thing that we used, the neurotransmitters and the story, we used a story to use the story as a mnemonic in order so that you do not forget the increase or decrease in neurotransmitters. So this has nothing to do with the disease itself. This is just a mnemonic. Okay. 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 Another thing that happens is another thing that happens is, okay, CAG. Okay, CAG stands for caudate, loses, ACH, and GABA. So with this, you can also remember that there's atrophy of the caudate and putamen. So once again, all the mnemonics, I'm going to write it down. Number 1, hunt for a cage. Okay, next one, hunt, name of hunter, losing, it's Gabe. Okay, next one, decreasing cold for decreasing acetylcholine. Okay, happy hunter for increasing dopamine. Okay, next one, caudate loses ACH and GABA for atrophy of caudate and the putamen. Okay, if you guys can remember the story and this mnemonic, you guys will not miss any questions about Huntington disease. Are we clear about Huntington disease? Of course, we will show you pictures about it and put them. We are saving these things for the last lecture so that in the last lecture, we will discuss about all the CT scans and MRI of the head. Are we clear? So that it's better we discuss everything then so that, you know, we can have a better understanding. So for right now, if we start discussing pictures, then it will take us away from our lecture over here. So do you think that's a better way to go, Dr. Iman? Okay. You got you work what structures of Huntington's disease? Okay. Okay, good. Okay, so are we clear about all? Okay, so are we clear about Huntington's disease now? Clear about Huntington's disease now? Okay. Okay. Once again, what do we see in the histological finding of Parkinson's disease? Fast answers, please. Do we see in the histological finding of Parkinson's disease? Lewy body. Okay. Alpha synuclein accumulation. Very good. Lewy body. Good. Next one, Alzheimer's disease. Okay, Alzheimer's disease, and Alzheimer's is the most common cause of dementia in the elderly population. So in geriatric population, if you have a patient who has onset of memory loss, the most common cause is the patient has Alzheimer's disease. And the thing is, even in patients who have Down syndrome, okay, Down syndrome patients have an increased risk of developing Alzheimer's disease. Why? Because the Alzheimer precursor protein, APP, Alzheimer's precursor protein, APP, which is responsible for the development of Alzheimer's disease, this protein is on chromosome number 21. And if trisomy 21, we know that Down syndrome is known as trisomy 21, meaning that there are 321 chromosomes instead of 221 chromosomes. So if we have one extra 21 chromosomes, will there be more APP or less APP? Fast answers, please. Will there be more APP or less APP in patients with Down syndrome? More, because the APP is on chromosome 21. So will there be increased risk of Alzheimer's or decreased risk of Alzheimer's? Increased risk, as simple as that. Okay, so if you have more APP, you will have more risk of developing Alzheimer's disease, and that's what it is. Okay, and another thing is, another thing is, you have another group of proteins known as ApoE2 or ApoE4. And what is the condition over here is, if you have ApoE2, then there's decreased risk of sporadic form. So sporadic Alzheimer's disease is the persistence or happening of Alzheimer's disease without a previous familial history. If a patient does not have a previous familial history and the patient have increase of Alzheimer's disease, if the patient has a sudden onset of Alzheimer's disease, then this is known as sporadic form or increase in Alzheimer's disease. If a patient has ApoE2, then the patient have decreased risk. If the patients have ApoE4, the patients have increased risk. How do we remember this? We remember this by just a small thing, that 4 is that APO4, the number 4 is more than 2. 4 is more than 2. So increased risk with 4, decreased risk with 2. Are we clear? ApoE4, increased risk. ApoE2, decreased risk. Okay. Okay, next one. Next one is, what do we see in a patient with histology or in a microscopy of Alzheimer's disease? What we see in a patient with Alzheimer's disease in histology or microscopy finding is, we see widespread cortical atrophy. We see widespread cortical atrophy. So if you can see over here that this patient, okay, so this patient in Alzheimer's disease, what you can see over here that there's cortical atrophy, meaning that the brain has become atrophied or small. As a result, you see that the ventricles over here has gotten bigger, and this condition is known as ex vacuo ventriculomegaly, the one that we talked about for Huntington's disease. Is that if the surrounding structures surrounding the ventricles, if they get small, the ventricles get big, and this is known as ex vacuo ventriculomegaly. And first thing that we see is cortical atrophy, especially in the hippocampus. Okay, especially in the hippocampus. So we have the hippocampus that is over here. Okay, over here. Okay, so these hippocampal atrophy. That's what's happening over here. So you get hippocampal atrophy. Along with that, what you get is you see senile. Okay, and along with that, you also see narrowing of the gyri and the widening of the sulci. Okay, so what you see is these gyri, they are narrow, and the sulci have gotten wide. Okay, so narrow gyri and wide sulci. So basically, let's say that this is the gyri and widening of the sulci. The sulci in between the two gyres have increased. Okay, these are increasing. So this is known as a cortical atrophy or atrophy of the brain, meaning that there is narrow gyri and widening of the sulci. Along with that, what you can see is you can also see this senile plaques in the gray matter. So this plaques, senile plaque, meaning that old plaques in the gray matter. Okay, and this could also mean that senile plaques are usually due to the accumulation of amyloid precursor protein. Okay, so amyloid precursor protein or Alzheimer precursor protein, APP. So these are basically the precursor protein, and we know what amyloids are. Amyloids are basically proteins that are very hard to break down or generate, right? So that's what's it. So first of all, we talked about synuclein. Synuclein was for Parkinsonism, and amyloid was we're talking about amyloid for Alzheimer's disease. So that's what it is. Okay, so Alzheimer's disease. There's another thing which we unfortunately have to see in Alzheimer's disease. There's another thing which is known as neurofibrillary tangles. These are neurofibrillary tangles. Okay, so what are neurofibrillary tangles? Neurofibrillary tangles are intracellular hyperphosphorylated tau protein. Okay, so there's another thing, unfortunately, that we have to see in Alzheimer's, and this is known as tau, T-A-U, tau. Tau is basically a hyperphosphorylated protein, which is present in the form of these shapes known as neurofibrillary tangles. Okay, and these neurofibrillary tangles are the amount at which they are present responds to the severity of the disease. Okay, once again, Alzheimer's disease. What are the things that we see in the histological finding of Alzheimer's disease? And this is important because there are a lot of things that we see. First of all, number one, cortical atrophy, atrophy of the corticals, narrowing of the gyri, widening of the sulci, especially hippocampal atrophy. Okay, so atrophy of the hippocampus. Number two, ventriculomegaly. Okay, ex vaccio ventriculomegaly. Number three, what do we see? What we see is senile plaques. Okay, or accumulations of amyloid precursor proteins, okay, or Alzheimer's precursor proteins. Number four, what we see, neurofibrillary tangles or hyperphosphorylated tau proteins, hyperphosphorylated tau proteins, okay. And last and foremost, there is another thing, unfortunately, that we see over here, okay, that is, okay, Hirano bodies, okay. I don't know why my internet is not working. Okay, 1 second. Okay, unfortunately, okay, so there's no need for you to see the picture for Hirano bodies, okay, but there's another thing that we see, that is Hirano bodies. But please try to remember the things that I just talked about. Number one is cortical atrophy. Number two is hippocampal atrophy, senile plaques, and neurofibrillary tangles. The number of tangles correlates with the degree of dementia. Okay, so that's that. So once again, I will give you guys 1 minute. I will give you guys 1 minute. In that 1 minute, I just want to see whether you guys remember all the things that you can see in the histology of Parkinson's, Huntington's, and Alzheimer's. And then we can only move on. So please review the text right now, the histological findings, before we move forward. Okay, so please review it right now. After you have done reviewing it, please say done. Okay, I would need the help of one doctor, one physician, only one physician. Okay, so whoever has not participated before, I will ask them to see whether they can participate, because the more you participate, the more clearer you will get. Okay, so I would wait for 1 minute. Please review the text in your book, the histological findings portions of the degenerative disease, that is Parkinson's, Huntington's, and Alzheimer's, and I will ask you the questions. Anyone who is confident enough can please say done. Okay, so 1 minute. Okay, good. Okay, so our first question goes to Dr. Iman, who is kind and brave enough to participate. So Dr. Iman, would you be kind enough to unmute yourselves and answer the questions?
Yes.
Okay, perfect. What do you expect to see in a patient, in a histological finding of a patient with Parkinson's disease?
Lewy bodies.
Okay, what are Lewy bodies?
It alpha synuclein.
Alpha-synuclein. That's very
Yeah,
good.
synuclein.
The name of the gene that is overexpressed for the formation of alpha-synucleins?
SNSA gene.
SNCA gene. Okay, thank you.
CA.
You know. Next question goes to Dr. Pravasi, who is also willing to participate. So thank you, Dr. Iman. The next question goes to Dr. Pravasi. Would you be kind enough to tell us what do you find in the histological findings of Huntington disease?
Lewy bodies. No. Oh,
For Huntington disease?
no. I got confused. Sorry.
No problem.
Atrophy of the coded and putamen nucleus, right?
Okay.
Sorry.
As a result, if you see atrophy of the caudate and putamen, what happens to the ventricles?
They're enlarged.
They get enlarged. What is the name of this condition of enlarged ventricles due to atrophy?
Ventromegaly.
Ex vecchio ventriculomegaly. Very good. Okay. And what happens to the neurotransmitters in Huntington disease?
We know that GABA is decreasing, acetylcholine is decreasing, dopamine is increasing.
Okay.
Yeah.
Perfect. Okay. And what is the gene that is, okay, so what is the name of the gene for Huntington disease that is damaged?
CAG on the chromosome 4.
Okay, so there are trinucleotide CAG repeats on chromosome number 4, but what is the name of the gene in which there is expansion?
You mean like autosomal dominant or what do you mean?
Okay.
The name.
Basically, the name of the gene is HTT. Okay. The name of the
okay.
gene is HTT, Huntington's. Hunt for a cage, meaning HTT, 4 for chromosome number 4, and cage for CAG. Very good. Okay, you've done a very good job. Thank
Sorry,
you.
one more time.
No problem. Okay, this means you were not looking at the book, so you have answered from what you have learned. So I appreciate it. Next one. Next one goes to Dr. Hussain. Dr. Hussain, would you be kind enough to tell us 1, 2, 3,
Yeah.
4 findings of four microscopical findings of Alzheimer's disease?
Alzheimer.
Number 1, Alzheimer's disease.
Cortical atrophy.
Number 1. Number 2.
Ventriculomegaly.
Ex vecchio ventriculomegaly. Number 3.
Yeah.
Number
Senile plaque.
senile plaque.
Yeah, and neurofibrillary tangle.
Okay, so senile plaques, what is the name of the protein for which there is the presence of senile plaques?
Beta amyloid.
Well, it's basically beta amyloid or basically amyloid protein. Okay, so that's good. That's a good answer. Next one is, what is the protein responsible for the formation of neurofibrillary tangles?
Neurofibrillary tangle protein. Tag protein.
Very good. Hyperphosphorylated tau protein. That is very
tau protein. Yeah.
Okay. And can you tell me if you have a patient with increased amount of ApoE2, will this increase the risk of sporadic Alzheimer's or decrease the risk?
Decrease for more than
okay.
Decrease, yeah. Decrease and 4 more, yeah.
4 is more, okay. What type of syndrome is associated with increased risk of Alzheimer's disease?
Down. Alzheimer's, Down syndrome.
Why?
Trisomy 21 and protein. And
so basically the answer is because there is an extra APP on chromosome number 1, so that's it. So
Very
good. Thank you so much, Dr. Hussain.
Okay, thank you for okay.
So that's basically all the things. There's another thing which I wanted to show you guys, that is Hirano bodies. Okay, so Hirano bodies are not that important. Okay, Hirano bodies are not that important to see because what they do is they focus more on the neurofibrillary tangles and the senile plaques. So that's what it is. Okay. Another thing that would make Alzheimer's disease a bit difficult is if you can please try to remember that there are some other proteins, okay, 2 other proteins, only 2 more that you have to remember for Alzheimer's, that is presenilin 1 and presenilin 2. Okay, so if you have familial forms, not sporadic forms, okay, so not sporadic, but if you have familial forms, then the presenilin 1 and presenilin 2 is also responsible for the formation of Alzheimer's protein, of Alzheimer's disease. So there are actually multiple things that you have to remember about Alzheimer's disease. That's why it makes
Alzheimer's disease, extremely difficult to study. Okay, but from what we have just heard from Dr. Hussein, who has read Alzheimer's disease once, she has been able to answer most of the questions about Alzheimer's disease. So I'm pretty sure most of the, I mean, the rest of you guys can do the same thing. Okay, and along with that, there's a last thing I want to talk about Alzheimer's disease before I move on to frontotemporal dementia is do you guys know what anticipation means in terms of trinucleotide repeat expansions? Anticipations. Anticipation. Excuse me. Okay, what is anticipation? What is anticipation? Start early. Okay. So which of the diseases will have severity increases with generations? That is a very good way to put it. Okay. So let's say if okay, so first of all, answer this. Which of the following diseases will have anticipations? Huntington's or Parkinson's? I mean, Huntington's or Alzheimer's? Huntington is all disorder over there. Alzheimer's disease, try to realize that there is no repeat expansion disorder in Alzheimer's disease. In Huntington disease, there's a repeat expansion disorder, and with every repeat expansion disorders, you have a condition known as anticipation. Now, the anticipation is, let's say a father has Huntington's at the age of 50. The son can get Huntington's at the age of 30. Okay, so this is known as anticipation, meaning that the severity and the onset of the disease occurs earlier with age as the disease keeps on progressing. So what happens is this keeps on happening until one generation is usually wiped out. Okay, so let's say a father has Huntington's at 50, the son will have Huntington's at 30, and if the son does not have any other child, right? Let's say by 30, a lot of males have not been fathering a child, and what would happen is if that patient dies from the disease, there will be a loss of an entire generation. So there is loss of an entire generation due to Huntington's disease as a result of a condition known as anticipation. So that's what it is, anticipation. Okay, so please remember that, anticipations. Okay, and we will talk about other trinucleotide repeat disorders in the future. Can you guys name one or two more trinucleotide repeat disorders, please, in which there could be anticipations? Examples are Fragile X. Very. Anything else? Anything else? Myotonic dystrophy. That's I wanted to hear about myotonic dystrophy. Ataxia. Okay, so these are some of the conditions of Friedreich's. That is very good. So Friedreich's ataxia. Then we have Huntington's disease, myotonic dystrophy. Okay, and then we have Fragile X syndrome, and these are all the trinucleotide repeat disorders. And in trinucleotide repeat disorders, we have anticipations. You have anticipations. So it is okay. And in anticipations, every generation, the onset of symptoms is worse. Okay, next one. Next one is frontotemporal dementia. Okay, so first of all, how do you diagnose Parkinsonism? You diagnose by TRAP. How do you diagnose Huntington disease? By these chorea athetosis and personality changes. I talked about this. Alzheimer's, how do you diagnose Alzheimer's? You diagnose Alzheimer's by dementia, that is onset of memory loss. Now we will talk about frontotemporal dementia. How do you diagnose frontotemporal dementia? You diagnose frontotemporal dementia by the fact that the first sign ever in frontotemporal dementia is changes in personality and behavior. Okay, so changes in personality or behavior. So if you have a patient with frontotemporal dementia, the first complaint that the patient's guardians or the patient's wife will have, or the patient's husband can have, is that the patient has a personality change. Okay, what kind of personality changes? Meaning that, let's say that the patient used to be some kind of a different type of a person. Now all of a sudden the patient's personality is changing. Now let's say the patient never used to be angry. Now the patient is always angry, or the patient was never upset about anything. Nowadays the patient is extremely upset about some things, and it makes absolutely no sense. And so personality changes for frontotemporal dementia is known as this is what you can see in frontotemporal dementia. So another thing is the frontotemporal dementia is also known as Pig's disease. Okay, Pig's disease. And the way I like to talk about personality changes and Pick's disease is, do you know do you know what I mean when I talk about a person who is extremely picky? What do you mean about a picky person? Picky. Have you guys ever used the word picky for a person that, okay, this person is extremely difficult to deal with because he's really picky with things, he likes a certain way? That's right, he's choosy, meaning that if things are not happening his way, okay, if things are not happening his way, then this really upsets him. Okay, so there's a certain way that he needs things to be done or she needs things to be done, and he's really picky about those things. And what happens when things are not happening that way? They get upset or they get angry. So picky is for personality changes. Okay, so picky person. So that's what it is. Okay, so next time you get a question about the fact where the question is emphasizing on the fact that the patient has changes in personality. Okay, changes in personality, the first disease that you should think about is, okay, the changes in personality, they're talking about a picky person, and the diagnosis is frontotemporal dementia. And what happens in frontotemporal dementia? What you have is you have frontal and temporal lobe degeneration, meaning frontotemporal degeneration over here. That you can see that the frontal lobe and the temporal lobe has degenerated, and the signs are cortical atrophies. As a result of this wide cortical atrophy of the temporal and the frontal region, the ventricle, as usual, has gotten bigger. This is also known. This is known as ex vaccio ventriculomegaly once again. So this is showing that there is widespread frontotemporal degeneration. That's what it is, frontotemporal degeneration. Okay, another thing that you will find over here is known as pig bodies. Okay, so you will find pig bodies. These are pig bodies. And what are pig bodies? Pig bodies are the same as more or less neurofibrillary tangles because there are tau proteins that are involved, and there is hyperphosphorylated tau proteins, okay, or ubiquitinated TDP43. This is not important. This is not that important, ubiquitinated TDP43, because USMLE has a lot of mercy on us I mean, like on you guys as students, right? Because they do not want to make things extremely difficult. So what they did was what they only do is they talk about hyperphosphorylated tau proteins or pig bodies. So these are the pig body here. Okay, so you do not have to think about ubiquitinated TDP43. So two things you find in frontotemporal dementia in histology, that is degeneration of the frontotemporal region, ex vaccio ventricularly, and pig bodies. That's what it is, pig bodies. Are we clear about frontotemporal dementia? Okay, okay. Last question before we move on to the next page. Okay, fast questions, and I expect very fast answers. Okay, first of all, you have a patient who comes to you with rigidity, bradykinesia, okay, akathisia, and then the patient has tremor. What is the diagnosis? This one is if you have a patient come to you with a gradual onset of memory loss, okay, gradual onset of memory loss, and the patient is an elderly patient. What is the diagnosis? As a patient who has come to you while flailing or flinging of the arm, along with that, the patient is showing signs, symptoms of aggression. Patient really not aggressive, 100% are aggressive. Is if a patient who has come to you with the fact that the patient used to be some other type of person, now the patient's personality has completely changed. Along with that, the patient has, okay, what is the condition? The name is from or Pick's disease. Okay, the name of the condition is Pick's disease. Okay, next one is Lewy body dementia. Okay, what is Lewy body dementia? Lewy body dementia is basically visual hallucination, and they have used a mnemonic such as hallucination. Hallucinations will help you remember that visual hallucinations are present along with dementia. So patients will not only have dementia, the patients will also have visual hallucination. Along with that, the patient will also have disorders of sleep, so REM sleep disorders. That's what it is, so REM sleep disorders. Okay, and another thing is there is a criteria for which you can by which you can diagnose Lewy body dementia, is because you can call the diagnosis as Lewy body dementia if the motor symptom onset is less than 1 year apart, meaning that let's say that the patient has motor symptoms, okay, and the motor symptoms have started, let's say, in the first year, okay, and let's say your motor symptoms start now, okay, and they keep on continuing for less than 1 year, okay, for less than 1 year they're still there, okay, and if the motor symptoms are there for less than 1 year, meaning that the motor symptoms are absent after 1 year, then this is known as Lewy body dementia. If the motor symptoms continue after 1 year, okay, then this is known as Parkinson's disease. Because in Parkinson's disease, you also get dementia and movement disorders, okay, but in Lewy body dementia, the motor disorders, that means the extrapyramidal movements, they're only present for less than 1 year. That's what it is. So they're only present for less than 1 year. So what are the things you can easily differentiate Lewy body dementia with? First of all, you will get dementia. Okay. First of all, what will you get? First of all, you will get dementia, visual hallucination. Okay. And then next, motor symptoms less than 1 year. Motor symptoms, which will stay for these three things for the diagnosis of Lewy body dementia, Lewy body dementia. And obviously, if the name is Lewy body dementia, then we will have accumulations of Lewy bodies. And once again, what are Lewy bodies? What are Lewy bodies? Guys, what are Lewy bodies? Can I get some answers? Synuclein, alpha synuclein, accumulations of alpha synuclein. Okay, are we clear? How about now? Is the voice breaking now? The voice is breaking now. Okay, so cool. Can you guys hear my voice now? Is the voice better? Okay, good. So have you guys understood about Lewy body dementia? Okay. Okay.
So Lewy body dementia, that's that. Okay. So once again, okay, I will share my screen, no problem. Once again, 1 second. Okay, Lewy body dementia. Okay. So the thing with Lewy body dementia is, before I move on to the differential diagnosis with Lewy body dementia, okay, before we move on to that, let's finish the next two dementias so that we can do a proper differentials of degenerative disorder. The next one that I want to talk about is vascular dementia. Okay, so what is vascular dementia? Basically, vascular dementias are the dementias that are occurring due to arterial infarcts or chronic ischemia. So basically, if you have a patient who has ischemia of the regions of the brain that are responsible for forming memories. Okay, and can we talk about some of the regions of the brain which are responsible for forming memories? What are the regions of the brain that are responsible for forming memories? Hippocampus and anyone? Temporal lobe. Anything else? Frontal, okay, frontal to some extent, not a lot, but hippocampus is very important. Temporal lobe, okay. Okay. How important is amygdala for forming memories? Very or not important at all? Amygdala, mammillary body. Okay. So basically parts of the limbic system. Okay. So basically most of the parts of the limbic system. So what are the parts of the limbic system? What are the Hammett? Very good. Okay. So what did we learn with Hammett? What are the parts of the limbic system? Hammett, H for hippocampus, H for amygdala, M for mammillary body, A for anterior thalamus. Then we have entorhinal cortex and cingulate gyrus. Okay, so that's what it is. So these are the parts of the limbic system, and more or less the limbic system is extremely important along with the temporal lobe, to some extent the frontal lobe too, for forming the memories. That's what it is. Okay, some memories are important. Okay, so if you have so are these parts of the are these structures supplied by blood vessels or not supplied by blood vessels? Yes or no? Very idiotic question or easy question, rhetorical. Of course they're supplied by blood vessels, because if they are not supplied by blood vessels, then they will undergo necrosis and then they will die. If you have decreased blood supply to these parts of the limbic system, will there be increased memory or decreased memory? Decreased memory. That is good. And this is known as vascular dementia. This condition is known as vascular dementia, in which there is multiple arterial infarcts of chronic ischemia, in which there is stepwise decline in late onset memory impairment. And this is the second most common cause of memory loss in elderly patients. Number one is Alzheimer's, and number two is vascular dementia. That is it. Number one is Alzheimer's, and number two is vascular dementia. Okay. So what we see is you have an MRI or CT scan, which will show multiple cortical or subcortical infarcts. Okay, once again, we will discuss the CT scans after the end of the lectures. So that's it. That's what it is. MRI or CT scan will show multiple subcortical infarcts. That's what it is. Okay. Next one. Next one is Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease. Okay. For Creutzfeldt-Jakob disease, this is a very high yield topic, because this is what USMLE will use to make hard questions, difficult questions. But first of all, we have to understand what this disease is. Basically, what this disease is, you have accumulations of proteins, and these proteins are known as prion proteins. Okay, prion proteins are basically beta pleated sheeted, okay, beta pleated sheet proteins, and these are basically PRPC, which is transformed to form PRPSC. PRPSC is basically the beta pleated sheet. And what happens is, when you have accumulations of this beta pleated sheet proteins in the brain, these proteins cannot be broken down by proteases. So we have proteases which are needed to break down the protein. And if these proteins are not broken down by the proteases, they will accumulate in the brain, and then they will cause the sign symptoms. Okay. Number one, now what is the sign symptom? So we have understood the pathology. Once again, what is the pathology? Accumulations of prions. Prions are basically, okay, so what are prions, please? What are prions? Fast answers. What are prions? Okay,
Prions are basically misfolded proteins. Okay, prions are basically misfolded proteins. Okay, so if there is the accumulation of this prion, that is beta pleated sheeted protein in the brain, they will cause the sign symptoms, and they are extremely hard to remove because they are resistant to degradation by the enzyme proteases. Okay, so as a result, what happens is you have patients which has progressive dementia, and the patient has myoclonus, and this myoclonus is known as myoclonus, startle myoclonus. Okay, one second, one second. Okay. Just want to show you guys the video about startle myoclonus. One second. Okay.
Do you mind if I just test the effect of a bit of a noise, a bit of a clap, not too loud?
Okay, so what is he going to do? He's going to do a clap or a noise. Okay, so see what happens after he does the clap or the noise. Okay, this is extremely interesting. So did you guys see what happened? Did you guys see what happened? This usually happens with little babies. Do you guys realize that with little babies, do you guys realize that if you have little babies and you scream or you clap really hard in front of little babies, they get startled? Okay, so once again, okay, let me just show you a very funny video very quick. Let's see.
Survive and thrive on the walls of handballs. You're complete. Press your tag and provide.
Okay, look at the video over here. Did you see what happened? Did you guys see what happened to that baby when he got startled? Okay, so this is the same as what happened to this guy over here. Okay. Okay, so this is the same thing that happened to the little baby and the same thing that happened to the adult. Okay, so what happened is startling is a reflex. Okay, startling is a reflex. Basically, we talked a little bit about Moro reflex, if you guys remember. Okay, so basically, re-emergence of primitive reflexes is a sign of degenerative disorder. Okay, so the baby and this older adult displayed the same presentations. Okay, display the same presentations, and this is known as startle myoclonus. Okay, and the reason why I emphasized on this video so much is because you will receive questions about this a lot, where they will try to explain what startle myoclonus is. Most probably they will not mention startle myoclonus in the question, but they will explain what this is. So now, since you know what startle myoclonus is, they will tell you that the patient has involuntary movements after the patient hears a wild clap. Okay, so if you hear something like this, you have to understand that they're talking about startle myoclonus. So if you have a patient with startle myoclonus and rapidly progressive dementia, the disease which you have to think about is Creutzfeldt-Jakob disease. Okay, Creutzfeldt-Jakob disease, and this is commonly seen with sharp waves on EEG, and increased amount of protein in the CSF, and the protein which is increased in CSF is known as 14-3-3. So 14-3-3. Okay, so this protein is increased in the CSF. So have you guys understood what startle myoclonus is? Okay, have you guys understood what startle myoclonus is? Okay, good. So with that being said, we have finished the neurodegenerative disorders. Now, before we move any forward, we will see whether you guys have understood what the neurodegenerative disorders are. Okay, we will ask you what the neurodegenerative disorders are. So, okay, first question, name of the disease in which you have tremor, rigidity, akinesia. pill rolling tremor, resting tremor. I mean, I know you guys know the name of the disease, but would you guys please humor me and write once again, Parkinson's? Thank you. Next one is if you have a patient who has wild flinging of the arm and onset of regressions, what is the name of the disease? Huntington disease. Next one is if you have a patient who has onset of dementia, which is the most common cause of onset of gradual onset of dementia, and it's a very old patient, Alzheimer's. Next one is if you have a patient who has come to you with first complaint of personality changes by the wife or by the husband. What is the name of the disease? And along with that, the patient has dementia, frontotemporal dementia. Okay. Next one is if you have a patient who has come to you with onset of dementia, along with that, the patient has involuntary movement of the hands and torso and legs after the patient hears a loud sound. What is the name of the condition? Loud sound. After the patient hears a loud sound, the CJ, meaning Creutzfeldt-Jakob disease. Next one is if you have a patient who has come to you with signs symptoms of ischemia and paralysis and the patient has dementia. What is the name of the condition? Vascular dementia. Next one is if you have a patient who has come to you with visual hallucinations and dementia. Visual hallucinations and dementia. What is the name of the condition? Lewy body dementia. Lewy body dementia. So do you guys realize how easy it is for you guys to diagnose neurodegenerative disorders right now? And I promised you guys I'll make it easy. So did I live up to my promise? Yes or no? Is it easy for you? Okay. Okay, so next time you guys receive questions and you will, are you going to be confident or not confident? Confident, very confident. Okay, I want each and every one of our students, okay, to be extremely confident when they answer something in the question. Okay, okay, so this is okay. So with that being said, there's a small thing which I want to let you guys know. Okay, so the brain is a very specialized organ, and the functions of the brain are still not 100% understood by a lot of scientists who have been trying to study the brain for a long period of time. So one of the things which your brain usually does is uh, consciously and subconsciously, your brain is picking up informations. Okay, your brain is picking up informations around you consciously and subconsciously, and whether you can or cannot access it, it's all up to you. Okay, so the thing is, on the day of your exam, when you are facing your USMLE step 1 questions, okay, you will come across a certain question or certain types of questions which you will have absolutely no idea about. Okay, you will have absolutely no idea about what the answer is. Okay, but your brain will have a very, very strong gut feeling. Okay, I mean, your brain will have a very, very strong feeling, or you will have a very strong gut feeling that, let's say the answer is A, or let's say the answer is B. And this feeling is not, and this feeling is not just you answering something based on your luck. What happens is your brain makes a very calculated decisions based on what you have learned in first aid, how many questions you have solved, how many things you have picked up. Okay, and then you answer that question. So what I need you guys to do is during that situations, if you decide on an answer which you have no idea about, but you decide that this answer is the right answer, although you are not sure why, but you have a strong feeling that this is what it is, please, please, please do not doubt yourself. Do not doubt yourself and change that answer. Okay, because it's absolutely impossible for you guys to know 240 out of 240 questions in the actual exams. I mean, yes, seven fours are 28. Sorry, 280 questions. My bad. So 280 questions. It's absolutely important, impossible for you guys to know 280 questions. So you guys will come across some questions where you have to make some gut feeling answers. Okay, and I promise you, if you stick to your gut feelings for those questions, your answer will be right. Your answer will be right. So do not doubt your brain. Okay, so with that being said, you will also get a lot of questions from neurodegenerative disorders, which will be out of context with first aid. Okay, but since you know basically what the name of the disease is, what you have to see in the histological findings, and what you have to see in the presentations, okay, you guys will 100% get all the right answers in your questions regarding neurodegenerative disorders. Okay, so with that being said, do we move forward with first aid, or what do you guys want to do? break, no break, you world notes, or no you know you world notes. Your choice. Break. Okay, so the thing is, instead of starting UWorld notes, okay, it's important that we finished. It's important that we finish first aid. So that's what we will do. We will read a little bit more about first aid, and what we will do is, before we do that, we would take another small break because we have just finished a huge topic, neurodegenerative disorders. Okay, you don't have UL notes, no problem. We will add you to our Facebook discussion group. We have a discussion group on Facebook where we share all the UL notes, and from there we will give you the UL notes. Okay, no problem. Okay, and I will provide the UL notes. I provide. So what we do is we provide UL notes for every student at the end of the lectures. So you will be getting it from today. So there's nothing to be worried about. Okay, so with that being said, let's take another break and then we can come back. How about that? Are we okay with that decision? Okay.
Okay, so is everyone back from their break? Okay, okay, good. Everyone else? Okay, good. Okay. So the next thing that we will talk about today is idiopathic intracranial hypertension. Okay, idiopathic intracranial hypertension. So far, okay, neurology could be a bit overwhelming, but if you have mastered everything, then it should be easy for you. So, from our previous knowledge of CSF drainage, from our previous knowledge of CSF drainage, what is the okay? What is the final step in the absorption of CSF? Does everyone remember? What is the final step of the absorption of CSF? Okay, venous sinuses. And where do the CSF come from the venous sinuses? Where do the CSF come? Through which structure? Arachnoid granulation. That is good. So CSF is absorbed from the arachnoid granulations. From there, they enter the dural venous sinuses. From the dural venous sinuses, what do? They go to they drain into the internal jugular vein. Okay, and from there they go to which organ? Where do they go to? Where do they go next? Very good. So that's what they do. They go to the heart, and especially in the right atrium, and then they circulate. Okay. So if I tell you right now that there is, if I tell you right now that there is stenosis, okay, if I tell you right now that there is stenosis of the venous sinuses, would you expect the intracranial pressure to increase or decrease? Increase intracranial pressure. Okay. So what? In this patient who has idiopathic intracranial hypertension, there is um, the name says itself that the intracranial increase in tension is idiopathic, meaning that there is no obvious findings on imaging, meaning that if you do an imaging of a patient, you will see that the patient's brain is more or less okay. Okay, but the patients have sign symptoms of intracranial hypertension. What are the sign symptoms of intracranial hypertension? I'm pretty sure you guys are dying to tell it out loud, but I will spare that. And I will tell you guys myself, okay, so what is happening over here is with increased intracranial hypertension, you have papilloedema, okay? And then if you do a lumbar puncture, you will see increased opening pressure. Okay, increase in opening pressure. So increased papilloedema, headache, okay, heaviness in the head. These are all the signs symptoms of intracranial hypertension. And what is the cause? Basically the cause could be idiopathic, but the association is important because it's associated with stenosis of cerebral venous sinuses. So as you have just said, if there is stenosis of the cerebral venous sinuses, there could be decreased drainage of the CSF, and this can increase your hypertension. So what are the risk factors? We have certain amount of risk factors, and thankfully first aid has provided us with a mnemonic. Okay, the mnemonic is female toad, female toad. So female toad are for female sex, and toad is basically females, toad for tetracyclines, obesity, vitamin A, and danazol. So danazol is a drug, and female toad, these are the things that are important for the formation of idiopathic intracranial hypertension. And the reason why you have to remember the risk factors is because in questions they will tell you, they will talk about a female who is undergoing treatment with either vitamin A, or there is a female who has some sort of a psychiatric disorder in which the female has an excessive tendency to maintain a healthy lifestyle, in which the female has excessive vitamins, in which the female has excessive vitamins. And if that kind of a thing is associated with increase in headache, papilloedema, and hypertension, intracranial hypertension, then the cause is idiopathic intracranial hypertension. Are we clear? Are we clear about the risk factors, why you have to remember them? Yes, no? Yes or no? Okay, good. So the risk factors once again are female sex, tetracycline, obesity, vitamin A, and danazol. So these are the risk factors you have to keep in mind if you want to associate the target question. That's what it is, okay? And another one is
basically, once again, if you do an imaging of the patient, you will see that the intracranial pressure is not increased. Okay, so please put 3 stars over here. My app Cami is not working today, so I cannot put the stars myself. Okay, so put 3 stars over here. Okay, so put 3 stars over idiopathic intracranial hypertension. This is extremely important, and please underline this whole thing. Okay, so underline the whole thing: female sex, tetracycline, obesity. This is important, and also underline cerebral venous sinus stenosis. That is the secretive cause. Okay. So once again, what do you see? You see headache, tinnitus, diplopia. Okay, and if you remember, I told you that even in intracranial hypertension, the cranial nerve, which will get paralyzed, or there will be a palsy, is abducens nerve. And the reason why I said that is because the sixth cranial nerve is one of the longest nerves. It's the longest cranial nerve in the central nervous system, and this nerve will go palsy. I mean, there will be paralysis or disruption of this cranial nerve structure, and we know that the cranial nerve 6 is associated for innervating lateral rectus. Okay, that is important for maintaining the proper coordinations of vision. And if there is a disruption of the cranial nerve 6, there will be diplopia. That's what it is. Okay, so once again, how will you get questions from this? You will get questions about a female who is either associated with tetracyclines or vitamin A or dinosol. Vitamin A, the questions will come with a psychiatric disorder, or the females, or that you will have a question about a female who is obese, and the female has signs and symptoms of headache, tinnitus, diplopia, papilledema, and increased opening pressure. So these are the sign symptoms, and they will ask you what the diagnosis is. The diagnosis is idiopathic intracranial hypertension. How do you treat a patient with idiopathic intracranial hypertension? First of all, is weight loss for obesity. And then you have acetazolamide. Acetazolamide is responsible for decreasing the formation of CSF. So CSF formation will decrease from the choroid plexus with the help of acetazolamide, which is a carbonic anhydrase inhibitor. And along with this, there's a surgical intervention. The surgical intervention is basically in CSF shunts. You can put CSF shunts, which will drain out the CSF, which cannot go through the cerebral venous sinuses. Okay, so that's that. Another one is optic nerve sheath fenestration surgery for visual loss. And this is not that high yield, so you do not have to worry about this. So do not underline this. Underline acetazolamide and CSF shunt placement. Are we clear about idiopathic intracranial hypertension? Are we clear? Okay. Okay, next one. Next one is hydrocephalus. Very easy to understand because we know the entire pathway of CSF drainage. Once again, can we do a small recapitulation of the pathway of CSF drainage, please? Who is willing to participate? I will ask one doctor so that they can tell me the pathway so that the rest of us can hear. Who is confident to talk about the entire pathway? Dr. Hussam. Okay, so since you said I can first, okay, so we will have Dr. Hussam and Dr. Mridula. Okay, we will have two doctors who will explain the pathway of CSF. Okay, Dr. Hussam, let me ask Dr. Mridula because she has not participated today, because since you have already participated once. Okay, so let's ask Dr. Mridula. Okay, so Dr. would you be kind enough to tell us the pathway of the CSF drainage?
Doctor, can you hear me?
Yes, I can hear you. So can you tell me the pathway of CSF drainage, please?
Yeah, CSF from the lateral ventricle, it goes to the third ventricle via right and left.
Okay, I'm sorry to interrupt in your discussion. Okay, first of all, I would like to know where the CSF is formed, where it drains, and where from all the way from the zero to the end, everything. Okay, so now you can start.
It is made by the choroid plexus in lateral ventricle.
Okay.
From lateral ventricle, it goes to the third ventricle via foramen of Monro.
Good.
And from third ventricle, it goes to the fourth ventricle via cerebral aqueduct.
Good.
And from fourth ventricle, it goes to the subarachnoid space via two ventricles, foramen of Lashka, that is lateral side, and foramen of Magendie, that is medial.
Good, very good.
And from subarachnoid space, it is reabsorbed by the arachnoid granules.
Good.
Yeah, and from arachnoid granules, it goes mainly to the suprasagittal sinus.
Superior sagittal sinus.
Superior sagittal sinus. and from there it goes to the internal jugular vein, and
Okay.
from interjugular vein to the right atrium.
Very good. That is the exact pathway of the CSF. So thank you so much, Dr. Mridula, for participating and telling us the pathway. I hope you guys have heard the CSF drainage. I'm sure each and every one of you, if asked individually, could have answered the same thing. Okay, so but since this doctor over here was more interested in participating, okay, so she has said the exact pathway in complete details, and we thank you for that. Okay, so the next one is, now we're going to talk about the pathology associated with this pathway. So that was the physiology. The pathology is, if you have blockage of any of that pathway, you get a condition that is known as hydrocephalus. I do not have to stretch more. You guys will know what this is. So basically what would happen is the CSF will keep on building, and since there is no drainage, there will be increase of CSF volume. If CSF increases, intracranial pressure will increase. Very basic knowledge. Next one is, what are the types? Types are basically you have a communicating and then you have a non-communicating. Non-communicating are the ones with obstructions of the pathway. So let's talk about this one first. So non-communicating is caused by obstruction of the CSF drainage. This can usually occur due to two reasons. For example, if you have stenosis of the cerebral aqueduct or aqueduct of Sylvius, this is the same thing. So cerebral aqueductal stenosis, number one, or if there's a colloid which can block this foramen of Monro. Foramen of Monro is responsible for draining from the lateral ventricles to the third ventricle, right? And from that, so if you have the colloid blocking that, so you will have expansion of the lateral ventricles. That's another cause of CSF. CSF. And the next one is a very easy cause to remember, that is tumor. So if you have a tumor which is blocking the ventricles, as usual, if there's a tumor which is blocking the pathway, the CSF cannot drain, so CSF will keep on building up. As you can see over here, that since there's a blockage of the CSF drainage from the lateral ventricles down all the way, maybe this is the patient with a cerebral aqueductal stenosis. Do you see how big the lateral ventricles have gotten? And this is known as hydrocephalus. Over here, what they are showing is they are showing a tumor, and for the tumor that you can see that there is expansion of the lateral ventricles. So that's the same thing. So this is your obstructive causes. Okay. Now we will come to non-obstructive causes in which there is no obstruction, but still there is accumulation of CSF. Number one cause could be there's a problem with arachnoid granulations, because we know that arachnoid granules are important for absorbing CSF. But let's say you have a patient who has a history of meningitis, okay? And meningitis is an infective disorder, and in chronic inflammation, we know that there's fibrosis, right? So if there is fibrosis of the arachnoid granulations, then what happens is, due to the fibrosis of arachnoid granulation, there is no proper absorption of CSF. As a result, CSF keeps on building up, and this results in increased intracranial pressure. It is not very hard to understand why this is happening. I'm sure you have understood communicating hydrocephalus due to arachnoid granulation fibrosis, due to post-meningitis fibrosis. Okay, next one. This is important for you to understand. What is normal pressure hydrocephalus? Okay, so normal pressure hydrocephalus, first of all, what we will do is we will address the presentation. The presentation of normal pressure hydrocephalus is done by W. W for the three things that will happen in your patient with normal pressure hydrocephalus. W for wet, W for wobbly, and W for wacky. Okay, so for wet, you have urinary incontinence. Okay, so meaning wet, meaning the patient has a problem holding on to their urine. Then wobbly meaning that wobble gait, or gait apraxia, magnetic gait. Okay, gait apraxia. And wacky for a wacky mind, meaning that there's a cognitive dysfunction. The patient is not cognitively sound. Okay, the patient is not cognitively sound. That's what it is. So if you have a patient who is presenting with these three things, wet, wacky, and wobbly, the first thing that you want to see, the first thing that you want to focus on is your diagnosis of normal pressure hydrocephalus. That's what it is. So in order for you to do that, you have to remember the W's. Okay, so what is this normal pressure? Basically, the cause is idiopathic. No one knows what basically the cause is, and the CSF is only increased episodically, meaning that the CSF is not always increased, but whenever it increases, the patient demonstrates these functions, okay, these conditions. And the good news about normal pressure hydrocephalus is the sign symptoms that is wet, wacky, and wobbly. They could be reversible if there is a proper CSF drainage, meaning that as if you come up. So how do you manage a patient with normal pressure hydrocephalus? First of all, the patient will come to you with sign symptoms of, let's say the patient will tell you that the patient has difficulty holding on to their urination. So the patient will complain about urinary incontinence. Keep in mind the patient himself will not complain about gait apraxia or wacky. Okay, you have to see that for yourself. So, and then when you do a neurological examination, you ask the patient to let's say walk for a little, and the patient expresses walking abnormalities, and then you ask the patient, then you do a mini mental state exam. Okay, and in a mini mental state exam, that is one of the that is one of the subdivisions of a neurological examination in a patient in the ward, and then you realize that your patient is not cognitively sound. So you make a diagnosis of normal pressure hydrocephalus. After that, you do a CT scan. In a CT scan, you see this type of image. Okay, then you confirm your diagnosis as normal pressure hydrocephalus. After that, what you do is you refer the patient to a neurosurgeon. The neurosurgeon will put a CSF drainage via lumbar puncture. And if there is CSF drainage, this will decrease the pressure, and then the sign symptoms will disappear. Are we clear about normal pressure hydrocephalus? Are we clear about normal pressure hydrocephalus? Okay. Okay. So that's that. So that's your normal pressure hydrocephalus. Okay. Next one. Okay. Next one is hydrocephalus mimics or ex vacuo ventriculomegaly. These are the things that we talked about before in degenerative disorder. If you have degeneration of a certain part of your brain, okay, as you can see that these parts have degenerated. Okay, so there is narrowing of the gyri and widening of the sulci. So narrow gyri, wide sulci, narrow gyri by this mouse over here, as you can see, narrow gyri and wide sulci. And for this, the ventricle has gotten bigger. This is known as ex vacuo ventriculomegaly. And we talked about a lot of conditions: Huntington's disease, we talked about Alzheimer's, we talked about Pigg's disease. Okay, so these are the conditions in which you get ex vacuo ventriculomegaly. And with this ex vacuo ventriculomegaly, you will not see wet wacky wobbly patients. Okay, that's that. So let me ask you a couple of questions really quick to see if you have understood hydrocephalus. First of all, if you have a patient who has come to you with cerebral aqueductal stenosis, what is the type of hydrocephalus? What is this type of hydrocephalus? Fast answers, please. Cerebral aqueductal stenosis. Obstructive or non-communicating? Okay, next one. If you have a patient who has a history of meningitis and now the patient has increased intracranial hypertension, what is the type of hydrocephalus? Communicating hydrocephalus. If the patient comes to you with urinary incontinence, difficulty in walking, the patient is not cognitively sound, what is the diagnosis? Normal pressure hydrocephalus. Okay. If you have a patient who has a history of who has a history of Alzheimer's disease, now you do a CT scan and you realize that the patient has ventriculomegaly. What is the name of this ventriculomegaly? Ex vacuo ventriculomegaly. Are we clear? Easy or not easy? Easy or not easy? Easy. Very easy. Okay. No, extremely easy. That's what it is. Okay, so now what we're going to do is we're going to start with demyelinating disorders, and there are a lot of demyelinating disorders which we're going to study. First of all, multiple sclerosis, osmotic demyelination syndrome, also known as pontine myelinolysis, Guillain-Barré syndrome, acute disseminated post-infectious encephalomyelitis, Charcot-Marie-Tooth disease, PML. Okay, and then we will move on to neurokidney disorders. Okay, so are you guys ready? Or do you guys want to start demyelinating disorders tomorrow? Which one? No. Okay, so we got one student who does not want to study neurokidney demyelinating disorders tomorrow. Okay, because there are a lot of things which we have to study about demyelinating disorders, and we do not need exhausted minds studying important things. Okay. Okay, tomorrow. Okay. So can I get some? Okay. So do we have? So do we even need to do any votings to see today or tomorrow, or is the majority tomorrow? No need to do votings. Okay. Looks like majority is tomorrow. Okay. All of you guys tomorrow. Okay, perfect. Okay, so even it sounds good to me too, because the reason being is because I can keep on teaching you guys. I have no problem. But You guys have to be the one who has to grasp the whole thing. So it's on you. Okay, so tomorrow it is. With that being said, thank you so much for doing the lectures for today. Okay, please do not leave. Okay, just because I'm saying thank you does not mean the lecture is over. I'm thanking you for keeping your attention during the first aid discussion, but we have a lot more things to discuss. Okay, we have a lot more things to discuss, and we will start with our U-World discussions. Okay, we'll start with our U-World discussion. Okay. Okay, so I'm going to stop sharing the screen for 1 second. Okay, 1 second. Okay, okay. So before we begin our U-World notes discussion, okay, do we have any student who has a question regarding transactions or regarding anything, regarding our lectures, regarding extensions? Okay, this is the best time to let me know. If you guys want, you can send me a private message so that I can acknowledge it. Anyone else? Because I received a lot of emails where you guys wanted to talk about something, talk about extensions and this and that. Okay, do we have anyone who needs to talk about something like this? If you can, please send me a message over here on Zoom, and I will see it right now and I will acknowledge it. Yes, the videos will be sent out to you guys today. Okay, we have made a Google Drive, and we will send you guys the videos by today. Anything else? Okay. Okay, videos, no problem. Okay, so anyone else who is there anyone who has any more questions regarding USMLE, regarding anything regarding the exam, regarding their study schedule, regarding their lesson plan, or when can they take the exam, based on what, anything you want to talk about before we start the UL notes? While I prepare the notes, now is the best time, because after the notes, a lot of students will leave. The pictures that you post on the group, that is a very good question. Okay, so we will discuss all the pictures that you post on the group, so keep on posting it and we will discuss it, no problem. Of course, we will take into consideration, of course, but the problem is with neurology that's been going on right now, we barely have time to do the UL notes and the UL questions. Okay, so but the thing is, if you keep on posting the questions in the discussion group, obviously it will get answered. Okay, so keep on posting the questions in the UL group and we will answer it for you, no problem. Anything else? What is the most important system in all of we have studied? Cardiovascular system and neurology. Okay. Yes, of course. I can reply to that email, no problem. Okay. The most important system in all of we have studied, cardiovascular system and neurology, which we are doing right now. Okay. Okay, you are welcome. Okay. Okay, 1 second. We will start. Okay, so for the purpose of the new students or student who has joined our lecture for today, if I have not welcomed you before, then let me welcome you once again. Okay, and this is the UWorld notes, which we have been making for the past 1 month. Okay, so these are all the UWorld notes which we have made for the past 1 month, and the easiest way you can access all of these notes is by entering our Facebook discussion group, the link of which we will send you today. Okay, we'll send you the link of the Facebook discussion group today, and you can access all of these notes from over there. Okay. Okay. Once again, in this UL notes section discussion, we allow you guys to unmute yourselves. Okay, unmute yourselves and answer questions which we will discuss, because what this will do is this will save us time and prevent us from going to the chat box and seeing who's answering what. Okay. At the same time, at times we also need your help. So that's that. Okay, so without further ado, let's start with our today's discussion. First thing that I want to talk about. Okay, so what are some of the high potent organisms for USMLE causing diarrhea? Go.
Clostridium difficile.
Okay, Clostridium okay, so the
Cholera.
question. Okay, one second. So let
Bloody.
me explain you the question. The question is basically, this is a question from MBOS, not UWorld, and MBOS has a list of 4 important microorganisms which can only cause diarrhea even if they're ingested in a very small amount, meaning that the
Shigella.
right. Okay, so number 1 is Shigella. Number 2, in very small amount, a little amount can cause diarrhea instantaneously.
Salmonella.
Salmonella.
E. coli.
Coli.
E. coli is not the
Coli.
Nope. Number 1. Okay, E. coli, Salmonella, you need to ingest them in a moderately large amount in order for them to cause diarrhea. Next one is did I hear anyone say Campylobacter? Because if I did, then that.
Campylobacter.
Okay, next one.
Cholera.
No, cholera.
Yersinia.
Yersinia, very close, but Yersinia is not the one. Anything else? Organisms. Please keep in mind they're not bacteria. They could be virus. They could be parasites.
Rotavirus.
Giardia. Babies.
Did anyone say Giardia? If they did, then this is the right answer. Last one is
Rotavirus.
okay. Good job.
Diarrhea.
Okay, I'm sure you guys know the answer. Okay, you guys were just hiding your knowledge. Okay, next one. Next one is, okay, bless you. Okay, hepatic steatosis. Okay, what is the biochemical? Wait, did we do this? Hepatic steatosis.
Yeah, we did.
We did this. 1 second. We did this. So hepatic steatosis, the biochemical problem with hepatosteatosis is decreased in free
Decreased
fatty acid.
oxidation of fatty acid.
Free fatty acid oxidation. That is correct. Okay. 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 The next one is just a statement. The statement is mineralocorticoid receptor antagonists such as spironolactone. Okay, this is not a question, this is just a statement. Spironolactone should be used in addition to standard therapy in patients with heart failure to prevent deleterious effect of aldosterone on heart. Okay, if you guys read this, you guys will understand. Okay. So mineralocorticoid receptors such as spironolactone should be used in addition to standard therapy in patients. Okay, so if you are using the standard therapy of patients, okay, we have to use spironolactone because to prevent the effects of aldosterone on heart. Okay, the effect of aldosterone on heart is not good for heart failure. This will exacerbate heart failure. So we have to use aldosterone antagonists. Okay. Next one. What is the treatment of ADHD? Anyone?
Methylphenidate. Amphetamine. Methylphenidate.
Amphetamines.
Maybe modafinil.
And amphetamines. Okay, next. Good. What happens? What is the pathology of ADHD? What is the problem? What neurotransmitter is decreasing in which part of the brain?
Dopamine.
And
acetylcholine.
And
No.
noradrenaline, maybe.
Very good. So norepinephrine and dopamine. Where is it decreased? In which part of the brain?
In the frontal cortex.
In prefrontal cortex. Okay, so where did you learn about this, Dr. Hossam?
Psychology, and I did research about it once.
Okay, but did you come across this question in UWorld?
No.
Okay, so if you didn't, then you will. Okay, so hopefully you can answer the right question. And every one of you, this is very important, okay, because this is asked at least 4 times in UWorld and 3 times in MBOS. Okay, so that's what it is. Okay, if you guys don't believe me about the numbers, then you guys can write it down. I can assure you that it's asked 4 times. Okay, so I have had one student who asked me once in the previous sessions that how am I so sure that they asked this 4 times or 5 times. How are you so sure? It's because I have written it down. Okay, because that's exactly how many times it's there. So that's why it's important. Okay, next one. Next one is, okay. Okay, so which cytokine is produced? Which cytokine is produced in response to viral infection?
Interleukin 12.
Nope. Interleukin 12 is produced, but not acutely. What is the number 1 cytokine that is produced?
Interferon gamma.
Interferons, yes.
Interferon. What type of interference? Type 1, type 2? Type 1 interference. And which one is it? Alpha, beta, gamma, which ones?
Gamma.
Gamma is not produced.
Alpha.
Alpha
Of
interferon.
course, it's alpha if it's not gamma. Alpha and beta.
Oh.
Okay, type 1 interference. Alpha interference. And what they do is alpha and beta, they bind to type 1 interferon receptors. And then what do they do? How do they? This is a very high yield UWorld question. I'm going to give this 6 stars. Okay, 6 stars.
Inhibit viral mRNA polymerase.
Okay, so what happens is, okay, so they do inhibit viral mRNA polymerase to some extent, but what they do is they form protein.
Decrease the protein synthesis in infected cells.
Right, but how do they do that? They do that by forming protein kinase R and RNASL, which halts viral protein synthesis. Okay. Okay. Have you guys received this question from UWorld yet?
Yes.
No.
Yes. No. Okay. So if you guys have not received it, then I can assure you will receive it. Okay. The question is they will ask you about the cytokine. That is one question, and the cytokines are not gamma. And the majority of students, they do respond gamma, and gamma is the wrong answer. The correct answer is alpha or beta interferon. And the next question which you will receive regarding this is if you know whether the association of protein kinase R and RNSL. So these are the things which are responsible for halting viral protein synthesis. That's that. Okay. Okay. Next one. 1 second. Okay. Okay. So, okay, I want to discuss about your knowledge regarding IV fluids. Okay. First fluid is isotonic fluid. What are some examples of isotonic fluid?
Normal saline.
Normal saline.
What is the
Glucose.
percentage?
5% glucose.
How much?
Lactate.
5%
0.9%.
0.9%. That is correct. 0.5% is absolutely not isotonic. Okay, 0.5% is hypotonic. Okay. Okay, next one is 0.9% normal saline. Another one, does it any other example?
5%
glucose. 5% glucose.
Nope, that's not isotonic. Isotonic. Have you guys heard about Ringer's lactate?
Yeah.
Yeah.
Yes.
Good. Next one, last one. How about 5% albumin? Is that isotonic or not? Okay.
Yes.
Albumin. Okay, now, what do we use isotonic fluid for?
For volume replacement in case of
Rehydration.
bleeding.
For rehydration
Rehydration.
Okay, resuscitation.
after diarrhea.
Okay, so if you have a patient who comes to you with bleeding, can you give them isotonic fluid? Yes or no?
Yeah.
Yeah.
Of course, you can give them isotonic fluid. Next one. Next one is hypotonic. Examples?
Less than 0.9.
Well, less than
0.9.
0. Okay, dextrose in 5% water. Or dextrose in 0.45% normal saline. Okay, so less than 0.9. There you go, 0.45%. Where do we use hypotonic fluid?
In hyper osmolar diseases.
Can use them also in DKA, in the last phase of DKA.
Okay, that last phase of DKA. But can we use this for hydration? Yes or no?
For maintenance.
No, we can't.
For maintenance.
Saline we can use.
Maintenance of hydration.
For maintenance.
Okay, so these are all examples. So DKA and everything that you have just said falls under this broad category. Next one, hypertonic. Example?
3% normal saline. 3% saline.
Okay, where can we use them?
In hyponatremic hyponatremia.
Okay. Can we use them slowly or fast?
No.
No.
Risk of
Myelinosis.
myelinosis.
Also
Contain myelinosis.
Slow infusion because of the risk of osmotic pontine demyelination syndrome. Okay. 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 So you have a patient with nephrotic syndrome. You have a patient with nephrotic syndrome. Okay. And on fluorescence study, keep in mind we have not studied nephrology as of yet. Okay. So if you guys can answer, that's good on you. Okay. But if you guys cannot, that's not your problem because we have not discussed it. But if you guys do come across questions, these notes will help you. Okay, so if you do a fluorescence study and you see linear deposits, what is the indication?
IgA nephropathy.
Okay. Anything else?
Maybe you mean Hinoch Splon Borbora?
Progressive.
How about anti-glomerular basement membrane antibodies? Are they linear or
good pasture. Good pasture.
Good pasture, but is it linear or not linear?
It's linear.
It's linear, yeah.
Exactly, it's anti-GBM antibody. Okay. And if you do a light microscopy of good pasture syndrome, if you do a light microscopy, what can you see in a patient? What can you see in the patient? Of good pasture syndrome? Light microscopy. If you do a patient, if you do a light microscopy of Gulenberg.
دوما حاجة كده.
Can you see crescents? Yes.
No.
Yes.
Crescents.
Yes.
Crescents I know in post-streptococcal. No.
How many?
Crescents is in rapidly progressive.
How many stages of rapidly progressive glomerulonephropathy are there?
3.
3. What is the type 1?
I forgot.
Okay, so you know what I'll do? I will skip this for later. Okay,
Excuse me, is it nephrotic?
Oh, don't forget it, doctor.
Okay, I will not forget.
Because when you say skip.
Okay, I will not forget it. Okay, I will discuss about this when we study nephrology, because we have not studied it as of yet, and it's not fair for you guys to learn about this since we have not studied it. Okay, let's talk about something else. Let's talk about signs symptoms of meningitis. Let's talk signs symptoms of meningitis with viral RNA in CSF and asymmetric, very high yield question, asymmetric flaccid paralysis. That's why it's in bold letters. What is the diagnosis, please?
Nile West River
Oh, very
virus.
good. Very good. Okay, who was the doctor who said West Nile virus?
Measure.
Okay, thank you so much for making the diagnosis and connecting the dots. The diagnosis is West Nile. And if you could just tell me the name of the vector which transmits the virus.
Mosquito.
Transmitted by
Molex or yes, Culex mosquito.
Okay, good. So if you have a patient who comes to you with signs and symptoms of meningitis, and then you do a CSF RNA study, you see a viral RNA, and the patient also has an asymmetric flaccid paralysis, this is extremely high yield for USMLE because this gives them the chance to make a very hard question about West Nile virus. West Nile virus comes with signs and symptoms of meningitis number 1, viral RNA and CSF number 2, and asymmetric flaccid paralysis that is number 3. Extremely important triad for West Nile virus. Please do not forget this. Okay, next one. And the problem is, even if you study microbiology, you will read through them. You will read through this without connecting the dots, and USMLE will strike it in the fact where you will just read through them. Okay, so this is very important for you to understand. Okay, next one. Next one is.
Excuse me, doctor.
Yes, what is your question?
There is my friend wait you to enter it.
My bad. Okay, I'm sorry.
Okay, thank you.
Okay, all right. Next one is okay. So for the new students who have just joined the lectures, we were talking about signs and symptoms of meningitis with viral RNA and CSF and asymmetric flaccid paralysis, and this association is extremely important for West Nile virus, and it's transmitted by female Culex mosquito. Okay, next one.
Okay.
Small intestinal bacterial overgrowth after gastrojejunostomy. What are the two vitamins that can increase after bacterial overgrowth after jejunostomy?
Vitamin K.
And
B12. B12.
Nope.
Not B12, maybe B9.
Folate.
Yeah, folic acid.
Folic acid. Yeah, sorry.
Okay. Very good. Okay. First, okay. Next one. This is easy. We just talked about this today. First line therapy for trigeminal neuralgia. Okay, first line therapy for trigeminal neuralgia.
Carbamazepine.
Carbamazepine. We have just talked about this today. Okay. Keep in mind, they will ask you a lot of questions regarding this. Okay. Okay, so there is another thing. Okay, I'm not sure if let me see one last time if my cam is working, so that because I want to draw you guys a diagram about one of the very high yield disease. Cami is not available. Okay, it's not available. Okay, 1 second, please. Let me see. Okay. Okay, I will discuss about this tomorrow then. There is one diagram which I wanted to show you guys. Okay, let me see if I can use something in Google. 1 second. I don't know. Okay, so let's keep on this. Okay, so I wanted to discuss about a picture of mature teratoma. Okay, so unfortunately I can't seem to draw today. That's been an issue. So I'll discuss about that tomorrow. Okay, next one. Let's use another one. Okay. Next one is in patients with atrial fibrillation and RVR. What is RVR? Atrial fibrillation and RVR. Anyone?
Right ventricular.
Rapid ventricular repolarization. Okay, atrial fibrillation and rapid ventricular repolarization. Okay, what we do is we do a radio frequency
ablation, okay, of foci on nodes. Foci on AV node. AV node, okay. So the question is, this is the question. The question is, what is the location of AV node? Location of AV node. We talked about this in CVS. I would expect you guys to remember.
Intra-atrial
Ventricular. Atrioventricular. So
What is the location, please, once again?
Here the opening.
Intra-atrial septum.
Yeah, in the right atrium, in the intra-atrial.
Interatrial septum. Then near the opening of
The
coronary sinus.
Okay, someone said coronary
Near
sinus.
atrium.
Someone said coronary sinus.
coronary sinus.
Okay. Next one, location of a SA node.
Near the
opening of
superior
superior
vena
vena
cava.
Vena cava.
Where?
Near
Near
the
the
opening.
opening of superior vena cava.
Okay, Dr. Adhanom, you are correct, and all the other doctors who said superior vena cava, they're also correct. So upper part of Krista, near the opening of superior vena cava. Okay, very good. Okay. In myasthenia gravis, okay, patients are extremely sensitive to one group of drugs. What is the name of that drug?
Anticholinesterase inhibitor.
Which one?
Hydrophonium.
Hydrophonium, yeah, hydrophonium.
Hydrophonium.
You guys know the name of the answer. Okay, I'm not going to discuss this. Okay, this is not hard enough. Okay, another. Next one. You have a patient who has come to you with damage to orbital floor. Okay, the patient was struck in the face with a baseball bat during a fight. Now the patient has damage to the orbital floor. What is the nerve that is damaged? Damage to which nerve?
Infraorbital nerve.
Very good. Did you guys come across this question yet?
Yes.
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 Infraorbital nerve. Infraorbital nerve. If there is damage to infraorbital nerve, what is the paresthesis? Where will the paresthesis happen? Which parts of the face will undergo paresthesia?
On the cheeks.
Cheeks.
Zygomatic area.
Paresthesia of and
Zygomatic.
And upper lips.
Upper lips.
Okay. Gingiva. Okay. What is the most common trigger for paroxysmal atrial fibrillation?
Alcohol.
Mitral regurgitation.
Nope. Aberrant electrical foci. Where is the foci present?
Near the venous open. Veins or pulmonary veins opening.
Which vein? Pulmonary vein. Okay. So if anyone is confused about a foci, so foci is basically an electrical foci. Okay. So this small piece of tissue in the pulmonary vein is electrically active, and this interferes with the nodal regeneration. I mean the nodal generation of impulses, and this sends its own impulses. And what this does is this causes paroxysmal atrial fibrillations. So that's what it is. Okay, that's that. Okay. Next one. Next one is okay. Patients with sickle cell crisis. Patients with sickle cell crisis. Okay. Can they develop macrocytosis or not? Yes or no?
Yeah. Yes.
Why?
Due to increased demand of folic acid.
Very good. Very good. Okay. So due to.
And before you ask, I came across this question. Yes.
Okay. Very good, Dr. Hassam. So I was just going to ask you if you came across this question in New World, and your answer is yes. So you did come across this question, and you wanted to increase demand of folic acid. Okay, so I am becoming excessively predictive. Okay, so you guys can predict exactly what I'm going to ask you. Okay, next one. Okay, next one is if you have a patient who has candidiasis, systemic candidiasis. I also talked about this. Systemic candidiasis. Which white blood cell has dropped for
Neutrophils.
Neutrophil.
Neutrophils.
Neutrophil.
Neutropenia.
How about localized candidiasis?
T cells.
T cells.
Okay, good. Okay, so decreased T lymphocyte. Okay, good. Okay. Can anyone walk me through the mechanism of granuloma formation, please? Okay.
Interferon gamma, interleukin 12.
Macrophages.
First of all,
Macrophages, IL-12.
1 second. Macrophage was, I will write APC. APC is antigen presenting cells.
Yes.
Okay.
IL-12.
IL-12. And then?
T helper 1.
T helper 1.
T cells. T cells, yes. T helper 1, interferon gamma.
Which interferon?
Gamma.
Then? And another
then macrophage to be epithelioid and enhance phagocytic activity of macrophage.
Okay, that's very good. But yeah, you have said everything except there is one small detail which you missed. Which one did you miss? So which one did this doctor miss? Can any other doctor fill that up? So she has
the gamma interferon will also trigger the antigen presenting cells.
No. I'm talking about the Th1 cells will secrete gamma interferon, and which interleukin will they secrete along?
IL-4.
Nope.
IL-2.
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 Okay, if anyone said IL-2, then they're correct. Okay, so they will secrete gamma interferon and IL-2. Okay, so what will gamma interferon do?
Enhance macrophage killing. Phagocytic killing.
Epithelioid, and that's okay. Phagocytic killing, that will happen obviously, but there will be epithelioid formations and granuloma. And what will IL-2 do? IL-2. What will IL-2 do?
Increase synthesis of T cells.
T cells activation, auto activation.
IL-2 will increase
T cell differentiation.
T cell to Th1 once again. And what will Th1 secrete now?
4.
You guys are leaving behind one very important cytokine which is responsible for maintaining the shape and size of granuloma. What is
so 1.
Interferons, TNF alpha.
Very good. Very good. Okay. So what's happening? First of all, APC will secrete IL-12. IL-12 will activate Th1. Th1 will secrete gamma interferon, interleukin-2. Gamma interferon will activate macrophage 2 epithelioid, and interleukin-2 will increase more Th1, and more Th1 will secrete TNF-alpha, and TNF-alpha will maintain the granuloma. Okay, so this is a very important mechanism of granuloma formation. Okay. Granuloma formation. Okay, what is the name of this? Okay, so did everyone understand about the mechanism of granuloma? Yes or no?
Yes.
Yes.
Okay. What? Is it possible to decrease the sound of the surrounding electronic structure, please? Anyone? Okay, thank you. So, okay, so if you have a chocolate agar mixed with antibiotics, what is the name of this? Media?
VPN.
VPN.
Oh, Thiamartin.
Thiamartin.
Thiamartin, yes.
Okay.
For Neisseria.
For which bacteria?
Neisseria.
Neisseria.
Okay, good. Okay, good. Next one. Okay. Predominant. Okay, once again. Wait a second. Okay. What is the name of the predominant cells found in fatty streaks? Okay. What is the name of the predominant cell found in
Foamy macrophage.
Very good. Macrophage. Okay. Okay, next one. Next one is an extremely high yield question. Okay. Okay. So it's a 6-star question because it's very different, very rare. Okay. Next one is have you guys heard about okay, so you have a patient, okay, so the question is about you have a patient who has undergone anesthesia, and after the patient has undergone anesthesia, during recovery of anesthesia, the patient is having a difficult time and the patient is taking a lot of time to recover from that anesthesia. Okay, you have, I'm not sure if you guys have received this question yet in UWorld or not. You guys will receive it. If you get a question like this, what is the first thing that you have to consider?
Hepatotoxicity.
No, there is a okay. There is an inherited.
Spinal shock.
It's due to an inherited enzyme deficiency. Do you guys know the name of that enzyme?
Acetylcholinesterase.
Slow acetylator.
Atypical acetylcholinesterase, I think.
Maybe pseudocholinesterase.
Pseudo. Okay.
Okay, so
I think it's like muscular relaxant.
Right. What is the name of the gene that is associated with this pseudocholinesterase deficiency? And Amboss has this question. What is the name of the gene that is responsible for deficiency of pseudocholinesterase? I do not expect you.
RYR?
Nope, it's RYR is for ranitidine.
Yeah.
Okay, BCHE gene. Okay, what is the genetic abnormality of pseudocholinesterase deficiency? Do you remember how we have certain genetic abnormalities like anticipations, allelic heterogeneity? Then we have, do you remember that genetic, that table in genetics? This is due to another genetic abnormality. And this genetic abnormality is due to genetic polymorphism. Okay, if you can't understand it, keep in mind, we will discuss about this later, no problem. Okay, due to autosomal recessive. Okay, so these patients have a deficiency in I mean, this patients are autosomal recessive for this gene, for which they have pseudocholinesterase deficiency, for which what is increased? Increased is succinylcholine. As a result, how long is the paralysis? Increased or decreased?
Increased.
Okay. Okay, due to degree. Okay, this is the whole information. So, pseudocholinesterase deficiency patients will have prolonged paralysis and prolonged signs and symptoms of anesthesia. Why? Because they are autosomal recessive for a gene known as BCHE gene due to genetic polymorphism, in which if there is succinylcholine, the succinylcholine will increase and keep the patient paralyzed for a long period of time, and there will be decreased plasma hydrolysis of succinylcholine. Are we clear?
Yeah.
Can I get 1 minute, please? Okay, so can you guys hear my voice?
Yes.
Yes.
Okay, so have you guys understood pseudocholinesterase deficiency?
Yes.
Okay, good. Okay, next one. Next one is neonatal abstinence syndrome. Okay, I'm sorry I'm getting so many phone calls. Please, can you give me another second? I apologize. I'm really, really sorry. Yes, hello. Okay, all right. Okay, once again, I apologize. Okay, next one. Next one is have we talked about the treatment of neonatal abstinence syndrome, guys?
Yes. Yeah.
What is the treatment?
Methadone.
And methadone and
Uh,
can we use
And
more?
Methadone and
Can we use more?
morphine. Morphine.
no.
Okay. Methadone and morphine. Okay, methadone and morphine. And but if we have to use morphine, do we have to be careful? Yes or no?
Yes.
Yes.
Okay, we have to be extremely careful. And the dose, the thing is, morphine is not widely used. Okay, methadone is widely used, but if methadone is not available, we use morphine, and we use morphine in morphine in extremely small doses. Okay. Okay. Next one.
Doctor, can you repeat for me phosphocholine because I'm out of internet connection?
Okay, so what is pseudocholinesterase? Pseudocholinesterase is an enzyme which is responsible for breaking down succinylcholine. And if you have some patients in which there is a BCHE gene due to genetic polymorphism and due to autosomal recessive condition, this gene results in decrease in this pseudocholinesterase enzyme. As a result, succinylcholine increases, and succinylcholine causes increased paralysis for a long period of time in patients. And this also results in decreased plasma hydrolysis of succinylcholine, of course, because the enzyme is not there. That's why. So these patients who are having succinylcholine during anesthesia, they experience prolonged anesthesia and decrease and increased time needed to recover from anesthesia, and also they have increased prolonged period of paralysis. Okay, are we
Okay,
clear?
thank you. Thank you. Yes, appreciate it.
No problem. You're welcome. Okay, next one is if you have a patient with anemia, constipation, and mental status changes with history of construction working. What is the diagnosis?
Lead poisoning.
Lead poisoning.
Very good, very good, very good. I was really hoping you guys would say that, and you guys did. Thank you. Lead poisoning. Okay. Okay. Last one. It's a biochemistry question. Okay. I'm not a big fan of biochemistry. Okay. In absence of pyruvate dehydrogenase deficiency. Okay. What should you supplement the diet with?
Lysine.
With lysine. Very good. With lysine. And
leucine.
okay. And
Valine.
Okay, and high fat. Okay. High amount of fat because fat is important for forming the pyruvate dehydrogenase. Okay, it's not valine by the way. Okay, so it's leucine, lysine, and a high amount of fat. That's it. Okay. I will discuss about this in details when we study biochemistry. Just because I do not like biochemistry does not mean I understand biochemistry. So don't get that wrong. So I also made the mistake of telling this to my previous set of students, and they were all disappeared during my biochemistry lessons because they thought I do not understand biochemistry. Okay, so that's that. Okay, so that's what it is. So thank you so much for doing the UWorld notes. Okay, so it's 1:50 as of right now. Do you guys want to do more questions, or do you guys want to stop over here and do the questions tomorrow? Okay. Anyone? Stop. Okay, stop. Okay. So we're all exhausted. We're all done. No one wants to do any more questions. Usually you guys want to do questions. That this is very surprising. Okay, this is very surprising that you guys do not want to do questions. Okay, so first of all, let me apologize for taking a bit of time to make you guys understand neurology. Okay, but I have to focus more on neurology because neurology is very important, and neurology is it really deserves a lot of time from all of us because if we don't perfect the concept regarding neurology, we cannot move forward. Okay, so having said that, please start doing your questions regarding neurology right away because I don't want you guys to forget, because we're spending so much time behind neurology. We want to make sure that we have perfected it in this time, in this period of time. Okay, we have not spent this much time behind any other topic. So neurology is extremely important. That's why, and it's very big. That's another thing. And there are multiple reasons which we have to keep neurology in mind. So please start doing your questions. Number one. Number two, do your world questions. And if you have any questions regarding our lectures, you can ask us in our email. Number two is I will send you guys the videos of the previous videos today. So we have a lot of students who asked for the videos, and I will send them out today. Okay, I will send you guys the links of all the videos. We have uploaded them, and we will send you the links for the videos today. That's number two. Number three, we have had students who have asked us if they could purchase our videos online, and the answer is yes. So if you have friends who are looking to purchase the videos online, okay, let us know. This will be this will be the same thing, the same transactions. The only difference is they will not be doing the classes, they will only be getting the videos. So we understand our classes take a lot of time, so if anyone wants to do the class at their own time, all they can do is access the videos by completing their transaction. So just let them know that we are ready to sell videos if they're looking forward to it. Okay, that's that. And also, if you have friends and colleagues who wants to come for one free class, depending that you know them, then obviously they're more than welcome to come and join us for a one free class. Okay, and number four, regarding the questions in the discussion group, which we will discuss, so you have absolutely nothing to worry about. Okay, of course I will upload the URL notes on Facebook right away. Okay, and number five is, if there's any one of you guys who have not completed the transaction, please complete it by today, because tomorrow, if we don't see the completed transactions from your end, we will not be able to send you the lecture links or the videos for this week. Okay, having said that, thank you so much for doing the lectures. And if you guys have any questions, please. Okay, and to all the doctors who wants the extent, who has told us about, I mean, who has warned us about the extension, they can take their time, no problem. But what we are speaking on behalf of all the doctors who have not completed the transaction, nor have they sent us any emails. Okay, so that puts us in a very difficult position. So once again, for all the physicians who has sent us emails about the extension, they're okay, no problem. We will send you the links. Okay, you can finish your transactions. We know studying medicine is difficult and it's expensive, and we don't want to add a burden to you guys. So if you guys need extension, no problem. But if you guys do not send us emails regarding your extensions, then we will assume that you guys do not want to do the lectures with us anymore. So we will stop sending you the lecture links. We will stop bothering you. So that's exactly the reason why, nothing else. Okay, so that's it. So having said that, thank you so much for doing the lectures. Okay, and if all is well, I will take my leave and see you guys tomorrow at 9 a.m. You guys are all welcome. Okay, Dr. Ahmed, you're welcome. Dr. Dalia, welcome. Okay, every one of you guys, welcome. Okay, Dr. Garbasi, welcome. Dr. Hussein, UWorld notes and videos. Yes, ma'am. I will send you the UWorld notes and the videos. Okay, I will send you the discussion group link on your email so you can join the group. Okay. Okay, all right. Have a nice day, guys. See you tomorrow.